honorable dignitaries, distinguished guests and faculties, and learned delegates, a very warm and cordial greetings and a very lovely noon to one and all. On behalf of AISMOC Organizing Committee, it gives me immense pleasure and a deep sense of pride to extend my gracious, humbled, and privileged welcome to all our benevolent guests. We at Jawaharlal Nehru Hospital and Research Center, Bhilai, are extremely honored and imperious for the opportunity to take the 42nd All India Steel Medical Officers Association Conference to an extra mile, and we wish it sparkles remarkably. Steel Authority of India Limited, the SAIL flagship unit, Bhilai Steel Plant, bagging the Prime Minister's trophy for the best integrated steel plant 11 times in a row, believes that Vidya Viniyogat Vikasaha, that progress comes from appropriate application of knowledge, and Nasti Vidya Samo Bandhu, Nasti Vidya Samasruhit, meaning there is no companion or bliss as great as knowledge. And to translate this knowledge into ideas which can influence, integrate, and glorify the minds and be brought into execution, today's session of this AISMOC pre-conference workshop has been designed. The true transformation begins with unlearning the wrongly learned and the ability to learn, de-learn, and relearn, and very importantly, to bring a change as an end result. So with the conference objectives of knowledge sharing, maximizing the learnings, and to facilitate academic discussions, we bring to you this noon a glad welcome filled with desires, hopes, and aspirations which we all share. So amidst the whole galaxy of intellectuals present over here, we feel honored to have amongst us our guest of honor for the ceremony, Honorable Executive Director, Personal and Administration, Shri M.M. Gadre sir. May I please request Dr. Vinita Dwivedi ma'am, our Chief Medical Officer and Head, Department of Anesthesiology, Medical and Health Services, to kindly escort our guest of honor to the dais. Thank you, madam. Most welcome, sir. Teaching begins being the greatest act of optimism. Its influence never stops. So to activate the magnets of curiosity, we welcome the noble faculty teachers, Dr. Shilpush J. Bhosle, sir, and Dr. Amol Kothekar, sir, our honorable faculties for today's session on hemodynamic monitoring. May I please request Dr. Joyita Sarkar, ma'am, and Dr. Amit Agrawal, sir, Chief Consultants, Department of Anesthesiology, to kindly escort honorable dignitaries to the dais. Dr. Shilpush J. Bhosle, Professor, Division of Critical Care, Department of Anesthesiology, Critical Care and Pain, Tata Memorial Hospital, Mumbai, with his expertise in pediatric regional anesthesia, is one of the most renowned intensivists and has more than 20 publications against his name, with a special inclination towards pediatric intensive care, hemodynamics, and ultrasound. Dr. Amol Kothekar, again Professor from Division of Critical Care, Department of Anesthesiology, Critical Care and Pain, Tata Memorial Hospital, Mumbai, with his expertise in management of sepsis and antibiotic policies, hemodynamic monitoring, ultrasonography, and 2D echo in critically ill patients, and also mechanical ventilation and blood gas analysis in neurocritical care, has more than 12 publications in national and international index journals. We are privileged to have you both, sirs. We treasure the presence of our Honorable CMO in charge, Medical and Health Services, Dr. Rabindranath M. Sir, who has been the guiding light and as Chairman of AISMOC 2023 has been a constant source of inspiration to guide and design the scientific sessions. We invite Dr. Sanjay Wane, sir, Additional CMO, Department of Anesthesiology, Medical and Health Services, Bhilai, to escort sir to the dais. Please, sir. Thank you, Sanjay sir. We cherish the presence of Honorable Mr. Sanjay Dhar, sir, Chief General Manager, Human Resource Development Department. We honor his prized presence, and may I please invite Dr. Shikha, Consultant, Department of Anesthesiology, to escort sir to the dais. We value the presence of Honorable Chief Medical Officer, Medical and Health Services, Dr. Pramod Benaike, sir, who because of his passion towards recent advances has been known for his knowledge and strong visionary leadership. May I please invite Dr. Tanuja Anand, Madam, Chief Consultant, Department of Anesthesiology, to please escort Dr. Benaike, sir, to the dais. We have amongst us very inspiring Madam Dr. Vinita Dwivedi, Madam, Chief Medical Officer and Head, Department of Anesthesiology, JLNHRC. We admire Madam's presence and we kindly invite Madam to please grace the dais. We would like to greet our honorable luminaries on the dais with flowers representing joyfulness, and to offer floral bouquet, may I please invite our postgraduate DNB residents from the Department of Anesthesia, Dr. Anurita, to present it to our guest of honor, ED, Personal and Administration, Ms. Shri M.M. Gatre, sir. We welcome you, sir. Dr. Palak to present floral bud to Honorable Faculty, Dr. Pushal Push Bhosle, sir. Dr. Manisha to honor Dr. Amol Kothikar, sir, with a floral tribute. Dr. Yogita to present floral bud to Honorable CMO in charge, Dr. Rabindranath M, sir. May I kindly invite Dr. Sunanda to offer floral bud to Honorable CGM, Human Resource Development Department, Shri Sanjay Dhar, sir. May I please invite Dr. Nidhi to offer floral bud to Honorable Chief Medical Officer, Medical and Health Services, Dr. Pramod Benaike, sir. May I please call upon Dr. Anurita to offer floral bud to Honorable Dr. Vinita Dwivedi, ma'am. It's an honored privilege to have amongst us the chairpersons for today's workshop, Honorable Dr. Shailendra Jain, sir, ex-director and former head, Department of Neurology, Medical and Health Services, Bhilai Steel Plant. We welcome Dr. Shailendra Jain, sir, with a floral bud. We have amongst us Honorable Dr. Jyoti Narula, Madam, ex-Joint Director and former Head, Department of Medicine, Medical and Health Services, Bhilai Steel Plant. We cherish Madam's graceful presence and we welcome Madam with a floral bud. We welcome Dr. S.K. Sethi, sir, ex-Joint Director and former Head, Department of Nephrology, Medical and Health Services, Bhilai Steel Plant. As a tribute of honor, we present a floral bud to Dr. Sethi, sir. We also welcome Dr. Meena Jain, Madam, ex-Director and former Head, Department of Obs and Gynae, Medical and Health Services, Bhilai Steel Plant, with a floral bud. So we cherish the long years of glory and jubilance we have had experienced under the leadership of sirs and madam. Thank you so much, sir and madam, for being present over here today. We also recognize the meticulous efforts and contribution of our enthusiastic BLS faculty team. So we welcome Dr. Tanuja Anand, Madam, Chief Consultant, Department of Anesthesia, JLNHRC, with a floral bud. Madam, please. Dr. Anurita to honor. Dr. Joyita Sarkar, Chief Consultant, Department of Anesthesia, Medical and Health Services, Bhilai Steel Plant. Dr. Amit Agarwal, Chief Consultant, Department of Anesthesia, Medical and Health Services, Bhilai Steel Plant. We also welcome Dr. Prakash Kujur, HOM from Vizag with a floral bud. Sir, you are most cordially welcome, Dr. Prakash, and Dr. Amit sir to give a floral bouquet to Dr. Prakash sir. Dr. Prakash sir, at present probably sir is not present over here. Okay, right sir, right. Yes, sure, absolutely. A big round of applause, right. From the team of BLS faculty, we welcome Dr. Shikha Agrawal, Consultant, Department of Anesthesia, Medical and Health Services, Bhilai Steel Plant, with a floral bud. So all these faculties, teamed and guided by Honorable Dr. Vinita Dwivedi ma'am, the BLS faculties, they have been consistently providing skill training sessions, both in-house and at various state and national level platforms, and have provided a leg up on the competition to our trainee resident doctors and nurses. No one can whistle a symphony alone, and it takes a whole orchestra to play a synchronized beat. Similarly, AISMOC 2023 is also a multi-pronged team-formulated program with some brainstorming ideas, clear goal plans, commitment, endurance, and high-quality exchange of ideas. And now to begin with the auspicious occasion and to bring greetings of hope and trust, and to be truly hospitable, may I please invite our Honorable CMO in charge, Medical and Health Services, Bhilai Steel Plant, Dr. Rabindranath M. for a formal welcome speech.
Very good afternoon to all of you. The essence of any event is to begin it on time. So cutting short all my formalities, I want to, I cordially welcome all of you, especially our Executive Director, M.M. Gadre sir, and along with him, the guest faculty from Tata Memorial Hospital, Dr. Shilp Pushp Bhosle Saab and Dr. Amul Kotekar, and all my friends over here from Vizag, from Bokaro and other hospitals, and my own team from Jawaharlal Nehru Hospital and Research Center. A hearty welcome to you, and my senior faculties are also there, Dr. Shailendra Jain, Madam Jyoti Narula, Dr. S.K. Sethi, Meena Jain Madam and others, and I heartily welcome to you so that we will begin this on time. Thank you very much.
Thank you, sir, for your compassionate welcome address. And as it has been said, intellectual growth should commence at birth and cease only at death. So to open the gateway to academic bonanza of 42nd All India Steel Medical Officers Association Conference, with great joy and immense exultation, I feel privileged to invite our esteemed guest of honor, Shri M.M. Gadre sir, ED, Personal and Administration, to bless this workshop and to declare it officially inaugurated. Sir, please.
Thank you, madam. Very good afternoon to all of you. Honorable Dr. Kotekar, Dr. Bhosle, Sridhar Saab, Dr. Rabindranath, Dr. Vinayake, Dr. Dwivedi madam, other senior doctors, DNB students, learned dignitaries, ladies and gentlemen. It's my privilege to be a part of this pre-conference workshop where we have got very eminent speakers with us. I'm finding myself alone in the galaxy of all the medical fraternity. To my mind, hemodynamic monitoring is basically a thing which you cannot ignore in any ICU management of any hospital. Basically, monitoring is a Latin word which means warning. So sometimes these monitoring systems, they can be considered as a kind of cognitive aids which gives a lot of useful information which is perhaps not possible with conventional physical examination. And the kind of inputs which you get from, like say, continuous electrocardiograph, then continuous blood pressure monitoring, then monitoring the oximetry level, and so on. So all these things, they not only help you doctors to take critical clinical decisions and enable you all to take some aggressive manipulation of critically ill patients. So today's topic is very apt, and as this hospital is attached with BHILAI steel plant, many critical patients do come here. So management of critical patients is very, very important. And we have got eminent speakers with us we have got a bundle of experience with them. So I will not take much time. We all are eager to hear them. So I declare this pre-conference workshop open. Thank you.
Thank you so much, Khatri sir, for your wonderful message and a formal inaugural. Thank you so much, sir. Before we shortly start the workshop, with an expression of gratitudeness, we thank all the dignitaries on the dais and off the dais. And may I please request our postgraduate DNB residents to escort our distinguished guests and faculties on the dais to their respective honored seats. So, again, gratitudeness is the fairest blossom ever, and to express thanksgiving, may I please invite Dr. Vinita Dwivedi ma'am to offer this vote of thanks. Madam. You will say, okay, divide over. Okay.
Good afternoon, everyone. Respected our guest of honor, AD Personnel and Administration, Mr. M.M. Gadre, Mr. Sanjay Dhar, CGM HRD, our CMO in charge, Dr. Ravindranath, CMO Dr. Binaike, our esteemed faculty of Tata Memorial Hospital, Mumbai, Dr. Shilp Pushp Bhosle and Dr. Amol Kothekar for the workshop on hemodynamic monitoring, and our faculty members of my department, Dr. Tanuja Anand, Dr. Jaita Sarkar, Dr. Amit Agrawal, and Dr. Shikha, who will be conducting workshop on basic life support. I would like to thank Dr. Shailen Jain, Dr. Jyoti Narula, Dr. S.K. Sethi for honoring the chair of chairpersons. I would like to express my sincere gratitude and thanks to all the delegations for their participations in the workshop. I would also like to thank Mr. Sanjeev Srivastav, SGM HRD, for helping us in organizing these workshops. Last but not the least, I would like to thank CMO in charge, Dr. Ravindranath, and the CMO, Dr. Binaike, for organizing secretary, Dr. Subodh Saha, and Department of Anesthesia for making this event a big success. In the end, I would like to thank Dr. Mala Chaudhary for conducting this workshop. On behalf of the organizing committee, we wish to express sincere thanks to honorable faculty and chairpersons for gracing this occasion, and my thanks to all the delegates for their enthusiastic participation. Now I would like to request the delegates who want to attend the BLS workshop to accompany the faculty and please go to lecture hall 1 so that they can attend that workshop. And I would like to please ask Dr. Shailen Jain sir to please accompany Dr. Amit Agrawal to the lecture hall 1. And rest of the faculty and other delegates, please I request them to stay here for the workshop on hemodynamic monitoring here itself. Thank you so much.
thank you all the dignitaries. So we shall split into two groups. The delegates who have registered for hemodynamic monitoring shall continue to stay over here itself, and the delegates who are registered for BLS workshop shall move to hall number, I guess it's to hall number 2. So they have to move to hall number 2.
This has been the first time that I've traveled to Chhattisgarh. I wish I could have spent a few more days here, but nevertheless, I'll hope to see you again. So I'll touch base on basics of hemodynamic monitoring, and that is on CVP and arterial pressure monitoring. Okay, and I will stress more on the critical aspect of like the critical care aspects of blood pressure and CVP monitoring, and not the non-critically ill aspects of monitoring. Okay, so when you talk about arterial pressure monitoring, I will stress more on the invasive arterial pressure monitoring. So how many of you routinely use invasive pressure monitoring? Can I have show of hands? Okay, so the key is because it is the realistic parameter for measurement of tissue perfusion. Okay, so we know when we are optimizing hemodynamics, we look at only two aspects. One is to optimize cardiac output. That is the aim, end goal of a resuscitation or hemodynamic optimization for that matter. So optimizing cardiac output and optimizing blood pressure. Okay, so we may not be able to monitor cardiac output most of the times, but what we monitor is blood pressure. Okay. So we all know the limitations of non-invasive blood pressure monitoring, and I'll stress a little bit on why we should use invasive blood pressure monitoring. So when we look at non-invasive, we've always been taught the way it is. So it actually looks at flow. So when you put a cuff around the arm, you inflate the bladder to obliterate the flow in the artery, and then you release the pressure in the cuff slowly till the flow starts. And once the flow starts, then the sounds that you hear is like described from the Korotkov sounds. But essentially, when you start hearing the sound, you reasonably assess that as systolic pressure, and when the sounds get muffled, you take it as diastolic. But the flow measurement or the oscillometric method uses the mean arterial pressure, and then it calculates the systolic and the diastolic. Okay, so that you need to remember. So the point at which the amplitude or the sound is highest in during the flow is considered as the mean arterial pressure. And I'll tell you why it is not very good. So there are numerous studies which have shown that non-invasive blood pressure has not been optimum in terms of monitoring critically ill patients. So here you can see that almost 2,700 patients who were monitored non-invasive blood pressure as well as invasive blood pressure, and they found that non-invasive blood pressure patients had higher AKI incidence. And that tells us that because we don't have a real-time monitoring which is continuous, we can see it at all times, and the essential nature of the non-invasive monitoring is that we do it intermittently. Though the blood pressure may be normal, like the mean arterial pressure was maintained, however there may still be episodes of hypotension which was not picked up, and that's why the AKI incidence was higher. And so there were also studies which looked at the AKI, not only the AKI incidence but also the mortality has been higher when patients were monitored on non-invasive blood pressure. You can see that the mortality rate is higher when patients were monitored with a non-invasive blood pressure. So point to be taken here is, if you have a critically ill patient, do not hesitate to monitor invasively. Okay? Right. Okay. So just to highlight the differences, you don't expect the same values, though we always take the mean arterial pressure to be reasonably same for invasive as well as non-invasive. Then you have other aspects, like in low flow conditions it will erroneously show lower readings, in high flow conditions it will erroneously show higher readings, and of course the invasive blood pressure is far better because it will give you real-time monitoring. Okay. Now I'll start with the meat of the discussion, is the invasive arterial blood pressure monitoring, and what information does the invasive arterial blood pressure monitoring gives you. And it gives you a whole lot of information. One is just looking at the characteristic of the trace. You will get, what you can see is the pulse pressure. Okay, so you get the systolic pressure, you get the diastolic pressure, and you get a very important aspect of measurement, and that is the pulse pressure. And pulse pressure, we all know, is just surrogate of stroke volume. Okay, so we may not be able to monitor cardiac output in all patients, but by looking at the pulse pressure, we have a reasonable estimate of the stroke volume, and that is a reasonable estimate of the cardiac output. Okay, you can look at the compliance of the arterial tree, okay, just by looking at the trace of the arterial pressure graph. Okay, when you look at the upstroke of the systolic upstroke, you will be able to roughly judge how good the contractility is. So the contractility is determined by the systolic upstroke or the velocity of ejection, and of course you can see the area under curve up to the diacritic notch. You will see what the area under curve is to give you the reasonable estimate of the mean arterial pressure. Okay, so that's how just by looking at the arterial pressure trace, you will get a host of information. Of course, you can use the arterial pressure trace to do more information or more monitoring in terms of cardiac output or pulse pressure variation, and assessing your fluid dynamics, whether to give fluids, whether the patient would be responding to fluids. All these aspects you can look at the pulse pressure variation and all, which Dr. Amol will highlight in the next talk. Okay, so how does the arterial pressure trace or arterial pressure system works? Okay, so you can see that you have a catheter into the artery. Okay, then there is a coupling system which is attached with a flushing system, because we don't want the catheter to get blocked. Then you have a pressure transducer. Okay, the pressure transducer is nothing but it is a device that will change the mechanical signal into an electrical signal. Okay, then you have a signal conditioner and amplifier. You have the analog that will convert the signal to a digital signal, and of course you have the microprocessor and the monitor. Okay, we need to know this because there are various points or places where errors can occur. Okay, and that's why we need to know the setup. Okay. Okay, so when you are, so it is easier when you apply the cuff on the arm, but when you are doing a non-invasive or the invasive blood pressure monitoring, you have to take care of the two aspects, that is zeroing and leveling. Okay, because that is what. So zeroing means you have to tell the transducer that the atmospheric pressure is 0. Okay, otherwise the atmospheric pressure normally is 760. You have to tell the transducer that the atmospheric pressure is 0. Otherwise, normally when we say our blood pressure is 120 systolic, that means it is 760 plus 120 in absolute terms. So when you tell the transducer that this is 0, the atmospheric pressure, you negate the atmospheric pressure and you get the real-time values. And of course, the reference is you have to level it at the phlebostatic axis. That is where the column of the blood would be when the heart is not working. Okay. Okay, now stay with me for understanding the mechanism of the arterial pressure trace, how it works. Okay, so I'll just take 5 minutes, but I want you to stay with me on this because this is a little complex. Otherwise, then rest I don't think it is pretty elementary. So here. So an arterial pressure trace is nothing but a wave. Okay, so when you have when the monitor or the catheter sees the arterial pressure wave, it is actually a series of waves. So for example, it is so you can see these are all sine waves. So it is akin to, suppose if you put a stone in the pond. Okay, so the stone, when it drops into the water, it will create a wave. But it will not create only one wave. It will keep creating waves. The waves will go and hit the border of the pond and it will come back. Okay, so the one stone drop or one drop of a stone will create multiple waves. Okay, so and the frequency of the drop of the stone is the fundamental frequency. Okay, so if you keep dropping the stone at 1 second each, your fundamental frequency will be 1. Okay, so Suppose, so now let's come back to, if you drop a stone, you have multiple waves. So one wave, if you drop it at every 1 second, you will have one wave at every 1 second, plus the other waves which are also going because of the first stone will also be added to it with the frequency, with the same frequency at which the first harmonic will be. Okay, so the analysis of these waves is actually termed as the Fourier's analysis. Okay, so when these waves are summated to get one characteristic waveform in the arterial trace, this analysis is termed as the Fourier's analysis. Okay, so now suppose if I drop one stone in the water, now there will be one wave, the other wave, till the waves die down, right? So most of the information, say suppose, so there may be suppose 15 waves that are formed. Most of the information is within the first 8 to 10 waves or 8 to 10 harmonics. And the transducer actually uses these 8 to 10 harmonics to give you the summated wave, okay, because most of the information is in that wave. So the summation of these waves will produce a characteristic arterial trace, right? So like I said, the frequency at which the stone is dropped is when the first wave is formed is the first harmonic. You can get up to 25 to 30 harmonics, but main information, like I said, is in the 8 to 10 harmonics. Okay, and that is what the monitoring system does. Now the second aspect is so every system has its own frequency also. So one is the frequency at which the stone is dropped, plus there is the frequency of the monitoring system. So the monitoring system's frequency has to be way higher than the frequency at which the stone is dropped for it to reliably measure and not cause an error. Got it? Okay. So ideally the monitoring system frequency has to be anywhere between more than 10. Normally we have almost 25. Okay, so the monitoring, so that you do not get the frequency of the system and the frequency of the arterial trace to coincide and cause resonance. Okay, you must have heard the story of the soldiers marching on the bridge, and when the marching frequency matched the frequency of the bridge collapsed because it causes increase in the resonance of the system. Okay, so that's why you want the monitoring system to have a frequency way higher than what the frequency of the arterial trace is. Okay, good. So if the heart rate is 60 beat, as I said, the fundamental frequency will be 1 because it is dropping at, or it is beating at 1 beat per second. Okay, so ideally your system of your frequency of the system has to be more than 10, and I'll tell you why. So that is the first aspect. Clear so far? Okay. Now, when we say natural frequency of the system, when we say natural frequency of the bridge, or suppose if you are sitting on the swing in the garden, the natural frequency of the swing, anything of that sort. So anything will have its natural frequency. So for the arterial system or the transducer system's natural frequency depends on this formula. So natural frequency, so you can see that this is the diameter of the catheter, and this is the length of the catheter, and this is the compliance or volume change by volume change in pressure. So your diameter has to be as big as possible. So if you are selecting an arterial catheter, you need to have a catheter that is as big as possible, but not as big to not allow flow around the catheter. Okay, not to obliterate the flow. The second is the length has to be as less as possible because the length is on the denominator side. And of course the compliance has to be stiff. Okay, so these are the three important aspects when you have to select the transducer system. Okay? Okay. Otherwise you will get something called as the resonance or damping. So you have to have a maximum diameter of the catheter, you have to have a minimum length of the catheter, and you have to have a system that is very stiff or less compliant. Okay, so how do you optimize the natural frequency? You need, like I said, all these things. You need a bigger catheter, shorter length, and so on and so forth. Okay. So how do you test the transducer system? So whether the transducer system's frequency is optimum or not optimum, how do you test it? So we test it by doing the fast flush test. Okay, so you have the monitor that is running at a speed of say 25 millimeters per second, and once you do the fast flush test, you will get something called as the resonance of the system. Okay, so you can actually measure. So suppose the amp or the width of the wave that is created after the fast flush or the flush is released, the width of the wave, suppose if it is 1 millimeter, then the natural frequency is 25 upon 1, that is 25 hertz, right? We want the system to be more than 10 hertz, like we said. So the system is 25 hertz, which is okay. If this width becomes 2 millimeters, your natural frequency of the transducer comes to 12.5 hertz, and then there is a chance that if the heart rate is say 120, you might end up having resonance, and the transducer may not optimally show you the correct blood pressures. Got it? Okay. So see, for example, now in this system, the frequency, natural frequency of the system is 25 hertz. So the system is reliable even if the heart rate is 180, because as I said, the first 8 harmonics, most of the information is in the first harmonic. So transducer will take 8 harmonics. Okay, so if the heart rate is 180 or the fundamental frequency is 180, and the total amount of harmonics that are considered by the transducer is 8, you will get a frequency is 24. So the frequency of the transducer is 25, so it can still reliably give you the blood pressure even if the heart rate reaches 180. Got it? Okay, great. So once this concept is clear, I think the arterial system is pretty much done. Okay, the other aspect is what is the principle by which the transducer measures blood pressure, and that is the Wheatstone bridge principle. Okay, so Wheatstone bridge is nothing but a series of resistors which are applied. So, and there are 3 known resistors and 1 is unknown. Okay, so what happens is, and those are applied in pairs. So you can see the R1, R2 and R3 are all known resistors, and the X is the unknown one. The resistor are connected to the circuit. If there is any change in the mechanical force which causes change in the resistance of the Wheatstone circuit, there is conductance of the current, and this current is displayed on the galvanometer. Okay, so that's how the unknown resistance is measured. Okay, so changes in current is happening when there is a change in the stretch of the diaphragm. The diaphragm is connected to the strain gauge, and the strain gauge the displacement of the strain gauge will cause change in the resistance and change in the current, and that's how much is the resistance is displayed by the transducer. Okay. To make the transducer more sensitive, the newer transducer, so previously we used to prepare transducers by ourselves, so we had reusable transducers, but nowadays we have the disposable ones. Okay, so previously we had to set up the diaphragm, make it less resonant, more low compliance, all these things we had to make it. Now we get a commercially available transducer which is even more better because it has got 2 resistors applied in pair, so that it improves the signal to noise ratio. Okay, so it makes it, in other words, it makes it more precise. Okay, how the setup is done is, you can see that there is a diaphragm, the arterial trace is, the arterial pulse is moving like this. The pulse generates the force on the diaphragm. The diaphragm is either made up of silicon, and the piezoelectric layer is connected to the diaphragm. So piezo means anything that changes shape. We have piezoelectric crystals in the ultrasound probe. So these similar piezoelectric crystals are attached to the diaphragm, which will change shape, and this will cause change in the resistance on the strain gauge. Okay. Now the other aspect. So first was the understanding the frequency of the transducer. Second is to understand how the principle of Wheatstone bridge works. And third is how to understand the system, whether it is optimally damped or under damped. Okay, so for example, if you have a swing, okay, so for example, if you put a if you drop a ball, okay, the ball will maybe bounce few times before it dies down, right? So it depends on how hard is the surface, how much pressurized is the ball. All these factors will cause the ball to bounce. Okay, so how the system reliably measures, because the system has to be optimally damped. Okay, and whether the system is optimally damped, we'll see from this fast flush test. So fast flush test will test the natural frequency and whether there is optimal dampening of the system. So dampening is the tendency of the oscillations to die down, because otherwise the system will keep oscillating and you don't want the oscillations to continue. So if you see the trace that is flatter, we say it is over-damped system. If you see the trace which is very spiking and very resonant, you can understand that the system is under-damped. Okay, you can see that the under-damped system will give you erroneously high systolic blood pressure. It can give you, and it can happen because of, long tubings, increased, resistance into the vascular tree. All these, like elderly patients and all, they will give you a under-damped tracing. So that's why in elderly patient you see a very narrow spiked arterial trace. And over-damped system, like I said, it will give you erroneously low systolic blood pressure. It is kind of a flatter trace on the monitor. And there are various things that can give you an under-damped and over-damped trace, that is air bubbles, clots and stuff like that. So, and you have to be careful about all these aspects. Okay. So, and you have to test whether the transducer is functioning adequately or not, because over a period of time the transducer may lose its accuracy, and by doing the fast flush test you have to always keep a check whether the transducer is optimally showing the readings. Because little bit of reading here and there may not have a big impact in arterial or blood pressure tracings, but for CVP or pressures where you have lower pressures, little bit of change in the transducer function may be giving erroneous values. Okay, so when we test the system, we call it the frequency testing or the checking of the frequency response. So how you do it is, again, you do a fast flush test or the square wave test, whatever we call it. So when you open the transducer and you release it, and like I said, you will get the resonance from the transducer, because the transducer, because the bag is pressurized and the column sees a higher pressure once you activate the flush. Once you release it, there is the inherent resonance of the system, which will give you this waveform. Okay, so you calculate the number of waves and you have the ratio of the second wave to the first wave. Okay, so we call it as the D2 by D1, and the ratio has to be at least 0.6. We call it as the damping coefficient. Okay, so if the ratio of the second to the first wave is 0.6, that is optimally damped. You do not want a system which is under damped. You do not want a system which is over damped. Okay, so you want a system which is under damped, and whether the system is optimally damped, you can test it by doing the fast flush test. Okay, like I said, you look at the ratios between the second and the first wave, and you can get the amplitude ratio or the damping coefficient. Okay. Like I said, we've gone through this. What are the prerequisites for having an optimal system? You choose the arterial catheter appropriately. You choose the length. You don't use a low compliant tubings and so on and so forth. Don't allow clots and all in the system. And you can have these charts for optimally damping, but these are more relevant when we had to do the manual preparation of the transducer. May not be applicable now because we have a ready-made transducers. Okay, and the last aspect is of the arterial system is to know the Wind-Kessel effect. So we know that the heart ejects blood in a projectile manner with every beat, but the flow in the tissues is continuous, right? So it is not, so though it is ejecting blood, the flow in the tissues is continuous, and that is because of the Wind-Kessel effect from the aortic fibers. Okay, so what happens is when the blood is ejected in the aorta in systole, the aortic compliance causes the blood to remain in the aorta, and once the aortic valve closes, because of the elastic recoil of the aorta, there is propulsion of the blood into the arterial tree during diastole also. So that's why though the blood is ejected only in systole, you have flow happening in diastole also, and that's why you get a continuous flow, which is important for the tissues. Okay, for tissues you need continuous flow, but heart does not eject continuously, it is ejecting as a pulsatile flow, right? So this Wind-Kessel effect causes this continuous flow. Okay, and why this Wind-Kessel effect is important is because as the age progresses, the elasticity of the aorta goes down, and that you can see from the arterial trace. Okay, that the aortic compliance is going down. Okay. So as the age progresses, you see you have a higher systolic pressure, as not much increase in the diastolic pressure, and that's why you get a widened pulse pressure in elderly population. Okay, so diastolic pressure is important for your coronary blood flow, and you can see that it does not happen very well if the aortic compliance is not very good. Okay. And why does that happen? Is because of this character of the wave reflection. So like I said, when the wave goes from all the vascular tree, the wave starts coming, reflecting back. So for example, if this is a pond, I drop a stone again, the same example I take. So if I drop, now the wave will be reflected from multiple obstructions, like it will reflect from the chair, it will reflect from the desk, and it is reflecting at various time intervals, right? Because depending on the length. And similar thing happens on the vascular tree. So from the nearer diversions of the vessel, the waves are reflected faster. From the distal vessels, the waves are reflected later. Now what happens is this reflection causes summation in the wave, or increase in the amplitude of the wave of the arterial trace. Now in younger population, because it happens because the vascular tree is compliant, okay, what happens is the blood is ejected and the reflected wave comes back in diastole, and that augments the diastolic flow, which is good for the patient. So in younger population, the reflected wave causing summation of the wave is good because it will augment the diastolic flow. But when in elderly population, as the arterial tree becomes stiffened, the waves are reflected early, okay, and that's why you might get reflection or augmentation of this flow even in systole. That will cause impeding of the flow, right? So you want a diastolic augmentation, which does not happen in elderly population. You get augmentation during systole, or the waves reflected in systole, and that causes erroneously higher systolic pressure and not so much augmentation of the diastolic pressure, and that's why the coronary blood flow is hampered, and higher systolic pressure causes increase in the SVR and increase in the impedance to flow. So the heart has to pump at against a higher pressure. So, and you will be able to understand all this by merely looking at the arterial pressure trace on the monitor. Got it? Okay. So like I said, for younger population it is better. In elderly population it is increasing the workload of the heart. And that's how various waveforms will look from distal arterial tree. And the last, which I will not go into detail, is the use of arterial pressure tracing to monitor fluid responsiveness in hemodynamic resuscitation or shock patients. So the amount of, so this is characteristically, because of the heart-lung interaction, as the heart-lung interaction causes change in the stroke volumes of the left and the right ventricle, it gives you a variation in the pulse pressure, okay, and this pulse pressure is quantified, which again you will get to know in details in the next lecture. You can actually say whether my patient is fluid responsive or not. In other words, if I give him volume or if I try to increase his preload, whether he will increase his cardiac output, because the whole exercise is to increase cardiac output, right? So the pulse pressure variation is important in that aspect. Now the second part of the discussion is on the mixed venous or the CVP. Okay, so what central venous pressure? Now again, how many of you measure central venous pressure? Okay, so because these are basic hemodynamic monitors, arterial pressure and central venous pressure. Okay, and if you can come back to the same formula, that it is the mean arterial pressure again is a reflection of cardiac output and systemic vascular resistance, and the only thing that can optimize cardiac output is by optimizing the preload, contractility and afterload, right? There are only three things that you can do. So when you have to optimize preload, the only way to monitor that is by virtue of a CVP. Okay, so okay, now coming back to the basic is the Starling's law. So what it suggests is if you increase the preload, your cardiac output will increase. It is by mere stretch of the myocardium. But we know that it is not everyone has got the same Frank-Starling curve. We have a family of curves, and it depends on the function of the heart, or that's why we call it as the cardiac function curve. If the heart function is not very good, you will have a flatter part of the Frank-Starling curve, and here you have to be cautious if you have to think whether increasing my preload will increase my cardiac output. Okay, here it may not be possible, but we do not see this. There is no way to identify very easily what is the cardiac function curve of a particular patient. Okay, so there are only few ways to do it, and we'll see how we can do it. Just to matter of completion is there is no way to that we should do it by saline manometry. We all should use pressure transducer to measure CVP as well. Like we use the pressure transducer to measure blood pressure, we should use the pressure transducer to measure CVP. For the simple reason is because manometric method is not a very sensitive method. It is not very sensitive to identify all the phases of the waves. Okay. And it is not very sensitive to also reflect the changes that happens with respiration. Okay, and CVP is nothing but the right atrial pressure in terms of the thoracic compliance. Okay, so you have to always reflect CVP in terms of compliance of the thoracic, whether it is lung or pleura or both. Okay. So like I said, the problems with the manometric is it is a very slow response and not a very good response, and it overestimates during positive pressure. So always use a transducer. The other aspect is because manometric method gives you in centimeters of water, and there is always a correction factor for centimeters of water, because 1.36 is the correction factor for centimeters to millimeter of Hg, and what we are actually looking at is the pressure in the central venous system. Okay. Now again, coming back to physiology is how does the CVP waveform look like, and what do we analyze? So you can see there are three positive waves, two negative waves. A, C, V and are the positive waves, X and Y are the two descents. Now again, A is because of the atrial contraction, C is because of the closure of the tricuspid valve. So when the atria contracts, so here suppose this is the atria contracts, so if you have a catheter in the SVC, now let's imagine that you have a catheter in the SVC which is looking at the pressure in the right atrium. Now when the atria contracts, the pressure in the right atrium increases, so you get a positive deflection, you get an A wave. Okay, now next is after the atria contracts, you will get the closure of the tricuspid valve. That closure of the tricuspid valve will cause slight increase in the pressure in the right atrium, which will cause the C wave, right? Then what happens is you will have this blood which is ejected, because now that the ventricle is filled and the blood is ejected from the ventricle into the pulmonary tree, you will get slight pulling of the tricuspid valve, which will give you a X descent, right? Then you will have the increase in the during the ventricle filling, you have the atria filling back during diastole, which will cause again the V wave. And again, once the tricuspid valve opens, the blood is gushed into the ventricle, which will give you rise, which will again drop the pressure in the atria, giving rise to the Y descent. Okay, this is only to understand why the ACV XY happens. We actually do not really see this in the CVP waveform. What we are more concerned is what is the number. Okay, and we'll see why. But we need to know what, because why it is important is because sometimes depending on the A waves or the V waves, you can identify what the pathology is. For example, the patient has got pericarditis or cardiac tamponade or atrial fibrillation. Just by mere looking at the CVP tracing, you will be able to identify what the pathology is. Okay, but what we are concerned is to have the number, and we need to know CVP. Like I said, you have to measure at the end of expiration. So in spontaneously breathing patient, you will see as the CVP graph moves up and down, because the end expiration happens at the upper end of the tracing. You will be able to measure the CVP at the upper end. In positive pressure breathing patients, you will measure the CVP at the lower end. This is in terms of respiration. Where do you actually look at the CVP is at the end of A wave. Okay, because you are looking at the CVP at the end of diastole. Okay, end diastole. So at the end of the A wave, you will measure the CVP. So in exam, if somebody asks you where do you measure the CVP, so you will be able to say at the end of A wave, and in terms of respiration, these are the two ways. Okay, like I said, CVP is always in terms of lung compliance. Okay, so absolute number does not have much value because it depends on what the lung compliance is and what's its effect on the CVP. So for example, if you get this CVP of 2 and here you have a CVP of 6, but you can see the thoracic or the lung compliance is quite poor. So it is akin to pressing the water bottle. So if you press the water bottle, the blood column will go up. It does not mean that the CVP is high, right? So because the lung compliance or the compliance of the chest wall or lung, whatever it is higher, the CVP is erroneously high. Does not mean that the actual filling pressures are high. Got it? So you have to always know what the CVP is in terms of the compliance.
So how do we standardize that depending on the lung compliance?
So there is nothing that we can alter the compliance, but we should be mindful that so for example in ARDS patient, if you suppose that ARDS patient is hypotensive and you see that the CVP is like 15, you feel that the filling pressures are very high, you may not, and if it becomes hypotensive, you may not erroneously not give the fluids thinking that the CVP is already high. So the best way to do is by putting an esophageal Doppler, esophageal balloon, and assess the compliance, and then you adjust. That is the difficult way of doing. The easier way is to look at fluid challenge, and I'll come to that. Okay, so like I said, in presence of hypovolemia, again it may erroneously tell you that the filling pressures are high and so on and so forth. So what is important is trend, and the response to infusion is important. So whatever the number is, you see whether there is a see, at the end of the day, you are interested in whether this CVP is adequate for his cardiac output or perfusion, and whether you want to increase the CVP by, or in other words, whether you want to increase the preload, right? So that's why one number is not important. And there are various, there is enough literature to say that CVP as a static parameter is not good. You have to always look at CVP in terms of fluid challenge, okay? So So how do you give a fluid challenge? Okay. So no exam would be complete without you knowing a fluid challenge. It may sound elementary. It may it may not be very clinically valid since we have very high-end monitors. But you should be able to describe how a fluid challenge is given. Okay. So there are four ways of doing, 4 aspects of doing fluid challenge. You need to know which fluid, what rate, what are the clinical endpoints, and what are the safety endpoints. Okay, so there are 4 aspects that you have to be mindful of. So what fluid, either you use a colloid or a crystalloid, what volume, well, if you are using a colloid, you can use 300 ml. If you are worried about the cardiac function or the cardiac function curve, you can use a mini fluid challenge. You can decide upon that. There is no fixed criteria what volume you can give. You can, if you are using colloid, you can use a little lower volume. Okay. Then what rate? So you can't just hang the fluid and give it for 30 minutes and say I have given a fluid challenge. So you have to be very precise about the rate. So you say, depending on the cardiac function curve, you say 300 ml in 15 minutes and you see what is the response. Okay, so what fluid, what rate, what are the clinical endpoints. So you have to predetermine what is your clinical endpoint. So either your clinical endpoint will be your CVP will increase from maybe 5 to 7 or 5 to 8, your heart rate may decrease from maybe 120 to 100, or your blood pressure may increase from maybe whatever 100 to 120, whatever. So you decide your clinical endpoints. Okay. Then you decide your safety endpoint. So what are the safety endpoint? One is, you see if your CVP jumps too much. Maybe if I say my CVP is 5 and my safety endpoint is 9, so I would stop if my CVP jumps to 9. So that is my safety endpoint. Or if you are using ultrasound, you will say that I will stop if I see increase in the B lines. Whatever you can use, as long as you are mindful that the amount of fluid is going to cause harm. Okay. So let's say, for example, you have a CVP of 8, you have a volume of 200 ml over 10 minutes, you see that the CVP rises more than 5. If it is yes, you have to stop the fluid challenge. If you say if the CVP is not increased by more than 5 and your clinical endpoints have not met, you can continue. If your clinical endpoints have met, you can stop. So it is a clinical tool. It is not like there is no hard and fast rule, as long as you know what to see and when to stop. Okay. All right. I think I'll stop here and take questions if there are any. So this is a workshop, so there has to be questions, like because this is not just a lecture. So I expect questions, doubts, either now or maybe later part of the day. Okay.
So this is a very complex topic for us, but still I would like to know that if we had used spirometry, means the respiratory this thing, and then suddenly feel loss of consciousness, postural, means from lying down supine to raising the head, sudden loss of consciousness. What may be the change in the pressure?
In the CVP you mean, or the blood pressure?
Blood pressure.
So any blood pressure that can cause cerebral hypoperfusion can cause altered consciousness. So we say postural hypertension. That can happen even when you mobilize your patient next day from the bed. So any pressure that is not enough to cause cerebral perfusion can cause loss of consciousness.
So what precaution to be taken for this patient?
So there are 2 things. One is whether the patient is optimally filled. We call it filled because your volume status should be good enough. That is one. Okay, and good enough is a very arbitrary word because it's a very subjective thing. And the second is whether the patient's autonomic function is good enough, because once the patient is, head is elevated, the autonomic system has to kick in to maintain the cerebral perfusion pressure. If that does not happen, maybe whether the patient is diabetic or, post-ops, that various reasons why the autonomic function may not be optimum. This is the classic setting where you have a cerebral hypoperfusion when you change the position.
Means due to autonomic instability.
Maybe one of the reasons, not always. If the patient's volume status is low, it can still be one of the reasons.
Sir, what will be the alteration of CVP in relation to the serum proteins level? Patient who are hypoproteinism.
So any pressure in the vessel has got either a hydrostatic component and an oncotic component. So oncotic component is an important aspect, but generally your live function is because of the hydrostatic one. So oncotic is a chronic element which is causing which is determining the pressure within the vessel. So like any low albumin status does cause edema, but whether it is the primary drive for less intravascular volume would be depending on the particular patient.
Like sir, hypovolemia is an effect that patient is experiencing less hypovolemia, so plasma volume is low. To maintain the intravascular volume, now the fluid will be mobilized from somewhere else, and then overall your sensitivity might be normal or maybe slight low. But it's very difficult to say whether patient has low albumin. That means CVP is low. It's very difficult to say.
There is no direct.
Problem with what we see in the chronically patients who are hypoproteinism.
So the albumin is low because of chronically being ill. That may not be the reason why the CVP is. Yeah. No, it is an excellent point that you have raised. Yeah, I agree with you because see, arterial lines in the operation theatre is a different thing. Arterial lines in the ICU is a different thing altogether. There is enough evidence to suggest that arterial lines have got similar catheter-related bloodstream infection rates as central lines in the ICU population. It may not be as much in the OT population. That is one. Second is, you do not want people putting arterial line at the drop of the hat when it is not needed, because again it's a procedure with its associated complications. Third is, you also want to know that if the patient warrants an arterial line, he should have one. And if you do not need, you should be as prompt in pulling it out like you would do it for a central line.
So what would be the contraindications of putting this transducer? As you said, the transducer means the dampening has to be optimal and the tubing compliance has to be strict. So whether there can be some contraindications depending on the pathological.
So, yeah.
What to optimize and what kind of pathological hemodynamic patient?
So now life is easy because now you don't have to assemble the transducer. You get commercially available transducer. Now what you have to do is you have to use the transducer just the way it is supplied and not make it less reliable by putting stopcocks or removing the connectors or adding more connectors, taking care that there are no air bubbles, there are no blood clots. So these are the things that normally should be good enough, because these transducers are reliable ones now.
So which artery is commonly used for radiation purposes?
So if the patient is very sick and maybe the radials are not well felt, you can put a femoral and immediately once the blood pressure is little better, you are able to cannulate the radial, you move to a radial because the infections are higher in the femoral ones. But by and large, radial arteries are good enough. We have a lecture on fluid responsiveness, on passive leg raising and fluid responsiveness.
The question about the type of fluid.
Which one is better one? Either CVP guided or the arterial line?
Either?
CVP guided monitoring is better one for the endpoint.
So that also will be there.
So as she has nicely mentioned, that blood pressure is not accurate because patient is in shock. The technique of measuring blood pressure is with the flow, which is not accurate in shock. So we need to have absolute pressure. That's why in patient in shock, cardiac surgery patient, in RMO, these patients we should put artery. Other patients not aware of research, it is no enough putting artery.
Selection of the patient groups which are more
Absolutely. And second thing, practical aspect. So if you permit, she has said, no, you don't have to know whether engine is 3-cylinder, 4-cylinder, or whatever. But you should know that we don't remember based on the what it is, but we should know if you drop transducer down, BP will be inaccurately high. So transducer goes up, BP goes inaccurately down. These are practical points.
That's why while addressing for invasive blood pressure, arterial blood pressure, to tell them what kind of operation is really required and what kind of, because once the gadget is there, like people are trained, you go on doing this to the other person. There will be some one is a big patient are really requiring in our.
Patients in shock is the reasonable starting point. Yeah. Right, we can move on. Okay.
Thank you, Dr. Sheel, for a wonderful lecture about blood pressure and CVP waveform. So this is a very difficult topic because it's all physics today. So I'll take first lecture on the role of ultrasound in shock, and then followed by Dr. Sheel will continue with his lecture on downstream parameters, and then I will talk about fluid responsiveness. So I would like to ask a question to all of you. So how you diagnose shock with ultrasound? The slides are not moving. So can anyone tell me please how will you diagnose? No, it's not. So what are the diagnostic criteria of shock? नहीं चाहिए. नहीं चाहिए. Thank you. So IVC collapsibility. What else? VTI. Okay. How much VTI? Okay. Ultrasound cannot diagnose shock. There is no way you can diagnose shock with ultrasound, right? Someone may have a EF of 20%, VTI of 10, but he is walking, he is living his life. He is not in shock. So ultrasound can never diagnose a shock. So what ultrasound can do? Or how you will diagnose shock? Shock is diagnosed based on clinical and biochemical parameters, not on ultrasound. Right? Cold climate extremities, decreased urine output. Then Dr. Sheel is going to talk about lactate and other parameters of downstream parameters of perfusion. All these things tell us about whether the patient is in shock. Ultrasound will never tell you whether the patient is in shock. Am I clear? So what is the use of ultrasound in shock? So ultrasound is used to diagnose the etiology of shock. We should know why there is a shock. What is the problem? And the best part of ultrasound is it is going to tell you at bedside immediately. Patients come in AD, you use ultrasound probe, in 5 minutes you have a diagnosis. This patient has myocardial infarction with pulmonary edema, this patient has a hypovolemia, anything. This patient has cardiac tamponade. In 5 minutes you have a diagnosis. And in next 5 minutes you have a plan of treatment. And you all know rapid treatment of shock will help in patient's outcome. That's why ultrasound is useful in shock. So, I'm sure all of you know the different types of shock. Distributive, cardiogenic, obstructive, hypovolemic. Distributive and hypovolemic, they have some overlap as far as echo is concerned. Other shocks are very clear-cut in ultrasound. So we'll just have a clinical scenario. Some elderly comes to with multiple comorbidities, comes to the ICU with cough, breathlessness, and he is initially tachycardic, some oxygen saturation is low, then there is a bilateral edema. Now, I would like to ask you a question, whether this patient is in shock? There is tachycardia, but is in shock. BP is 120 by 90. Can he be in shock? So even with normal BP, patient can be in shock. So I think this information is probably inadequate to tell whether patient is in shock. We need to know patient's mentation. What else we should know? Sensorium, urine output. What else? Pulse volume or temperature difference, capillary refill time. All these things are important. So as of now, we don't know. Let's assume this patient is in shock. So what could be the patient's problem? Or maybe he's in early shock, not frank overt shock right now, but he will go in shock in some time. So what is the problem in this patient? What is the differential diagnosis? There's a cough. I'm not sure about fever, breathlessness, elderly. It can be cardiac failure. Can it be pneumonia? What else it can be? So it can be anything, right? It can be pneumonia, MI, congestive cardiac failure, DVT, or with pulmonary embolism. So now how will you diagnose? So there is a protocol. So any patient coming to either ED or ICU with shock, you can use ultrasound and get your diagnosis in 5 minutes. You have to go by a protocol. There are many protocols. If you go on net, you have many hundreds of protocols. Most commonly used is called RUSH protocol. Rapid ultrasound in shock. And what they use simple approach, pump, that is heart, tank means the veins, IVC, and pipe means whatever there is in front of the pump. So this is a RUSH protocol. And in RUSH protocol, you will not do only echo or only lung ultrasound. You have to do a combined 4 ultrasound. One is heart, other is IVC, lung ultrasound, and also look for abdomen and also deep vein thrombosis. So everything you look. And when you use RUSH protocol, suppose you have a hypovolemic shock, you will have a hypercontractile LV, flat IVC, and there might be or may not have these issues in the like abdominal dissection or aneurysm. They can also cause hypovolemic shock. So depending on the case, you will have any of these parameters. In cardiogenic shock, you will have hypocontractile LV, distended IVC. They will have lung rockets, pulmonary edema. In obstructive shock, depending on what the cause is, you will have different ultrasound features. If there is a pulmonary embolism, you can have a deep vein thrombosis in the veins. If you have a pneumothorax, you will identify it in the lung ultrasound. And cardiac tamponade can be identified on the echo. And as I said, distributed shock is little mix. So you can have a mixed picture of, normally it will be like a hypovolemic shock with a hypercontractile LV. Now, I'll just brief. So obviously if you want to learn the echocardiography, it's a full day workshop for a shock, but I'll try to give you some idea of how many of you do echocardiography here or ultrasound? ultrasound for line cannulations. And echoes? Okay. But echo in the office, OPDs, or in the bedside? Bedside. In ED or critical patients? Okay, great. So, for the others, I'm just going to tell you briefly about the choice of probe for echo and other ultrasounds. I'm sure you must have seen all these probes. So, for those who are not used, this is a linear probe which is a high frequency, which gives very good resolution. This is very good for DVT screening, vascular cannulation, and if you want to look at lung sliding, lung pulse, this is very good. It is not good for echo and abdominal ultrasound. These two probes are interchangeable because many of you, in your hospital you may have only echo probe or only abdomen. That's okay. Any one of these probe will suffice. So with these, so if you have echo probe, you can use, this is very good for echo. This is called phase array probe. Very good for echo. You can do abdomen, that is called fast. Lung ultrasound, DVT scan you can do. It's not that it's absolutely no, you can do it. But this is not for vascular cannulation. Abdominal probe, again you can do fast lung ultrasound. You may do echo and DVT, but it is not advisable for vascular ultrasound. But if you don't have any other probe, it's better to do, better to have some idea with this probe rather than doing it blind. If you are doing echo, these are three common windows in critical ill patients. In patients, in OPD patients, people also use sometimes suprasternal view. In ICU patient on ventilator, you will not get a view here. So these are three common views, out of which the subcostal view is very easy in ICU patients on ventilator. Please stop me and ask me if you don't get anything. So I'm not going to tell you how to obtain a window and all this. No, I cannot. I will not be able to cover that. I'll just give you a brief idea of how to interpret a echo image. So if you are in ICU or ED, someone is doing echo. Just looking at the echo, you can look at the heart and see whether the heart is good or bad. I am not going to go what view is this, whether it's a parasternal short axis or whether it's subcostal 4-chamber view, but just look at the heart function. Look at this heart function, so look at this heart function. So, and I'm sure I had not put anything here because I know this is self-explanatory. Out of these two, how the contractility here? Good or bad? This one? Okay. Okay. How is the contractility here? Good or bad? It's poor. And this is? Good. It's simple. Let's move on to next one. Again, there are two different echo windows. So let's not go into, just look at the heart function. Look at this heart function. This is good or bad? Bad. And here? Good? Okay. One more slide. So, again, I don't have to put the words here. So I'm sure everybody is getting here. So only one tip I'm going to give you. This is called eyeballing of heart function. So in critical patient, you don't have time to measure the ejection fraction. It's very complicated. It's not easy. But believe me, if ejection fraction is 50% or 55%, it doesn't make any difference to me. I want to know whether ejection fraction is 50% or 20%. Whether it's 20%, 40% or 60%. I want to know gross. I don't want to know exact number. So what I do is called eyeballing. And this is the technique of doing eyeballing. So this is the technique of doing eyeballing. When you're doing eyeballing, always first you look at the endocardial body. I'll go back to previous slide. See, never comment on contractility if you can't see the endocardial border. See, there are three borders. Outer one is hyperechoic, that is epicardium, then myocardium is little hypoechoic. The lower one is hyperechoic, that is endocardial border. If you can't see endocardial border, don't interpret LV function. You need to have an endocardial border seen. So that is one thing. So look at the endocardial border. Look at the mitral, this is called mitral annulus. Look at the movement of mitral annulus, whether it's moving up or down, how fast it is moving. Look at the change of the geometry. Look at the, and if you are looking at the myocardium, always look at the myocardium. This is myocardium, inner hyperechoic. I'll move on to the next slide. So, this is myocardium. So, look here whether it's thickening or not. See all these four parameters and then only you say whether patient is LV function is good or bad. Am I clear so far? Okay. So, this was without IVC measurement. So for a physician who is doing an echo report, if he doesn't see RA is not dilated, he will not look at the IVC. But that is not the case for ICU. For ICU, IVC is very important. And I'll explain it to you later why IVC is important. So here we are going to look at the IVC. One thing you need to remember, when you are looking at the IVC, you should be sure it is IVC, not aorta. There are two structures here. So tell me which one is IVC and which one is aorta. Let's play both the videos. Why so? So if you trace this structure, it opens directly into the heart. If I trace this structure, it looks like, it appears like it's going into the heart, it is not going into heart. This is aorta. Second thing, can you see hepatic vein opening here? Here there is no hepatic vein opening. So these are two important criteria. Other criteria you can say this is thick wall, this is thin wall, this is pulsatile, this is not as much pulsatile. But most important is these two parameters, opening into the heart and looking at the hepatic vein. So this is the differentiation between IVC and aorta. And I am going to emphasize this again and again, and I am going to tell you reason. For example, if you have a patient with gross hypovolemia, severe hypovolemia, you put the probe, you are looking for the IVC, what will happen to the IVC? IVC is very, very collapsed. It's so collapsed that you cannot see IVC. And now the problem is, you can easily see aorta. Now if you don't know that is aorta, if you assume it's IVC, you will wrongly label this patient has a good volume, and you will mistreat this patient. Now this is more dangerous. Misdiagnosis is more dangerous than someone who is just looking clinically. He will say patient's tongue is dry, or patient has so many loose motion. Let's give some fluid, and you are confident you are putting the probe and saying, oh, IVC is full, but it is not. It's aorta. So please, when you are doing IVC assessment, I always recommend check both IVC and aorta. IVC is slightly on right side, aorta on the left side. If you have a doubt, you can use Doppler. Doppler flow in IVC is more or less continuous with respiratory variation. Here the flow is pulsatile. But sometimes, even the flow in IVC might be pulsatile because of high CVP, TRJ, there are many reasons. So, two primary things to remember is opening into the heart and opening of hepatic vein. I am showing IVC and aorta in the same patient. Just to emphasize the point. In the same patient, when you are putting the probe, so if you put the probe like this, if you are looking towards right side, it's IVC. If you look towards left side, it is aorta. Am I clear? So like we had seen for LV, we can also do visual assessment for IVC. Always you don't have to measure, you can just look at the size and see whether IVC is completely collapsed or it's collapsing intermittently with respiration or it's completely full. So you did ultrasound and you saw this IVC. Is fluid indicated? Always? Any other answers? Any from this side?
Sir, in cases of ascites or some,
Absolutely.
IVC could be
Absolutely.
outside pressure.
If there is no ascites, is fluid indicated? So only if patient has shock. If patient doesn't have shock, that patient doesn't need fluid. So if CVP is low, doesn't mean you should give fluid if the patient is not in shock. Same thing.
Sir, if patient is on mechanical ventilation, normal ventilation or mechanical?
Any patient. Any patient, you can look at the end expiratory diameter because that is the least of the respiratory interference. So in mechanical ventilation, IVC distance. So patient on ventilator, IVC is collapsed, that means patient is hypovolemic. If patient is in shock, you should give fluid. And what are the cautions or exceptions? Why in ascites you are saying IVC is? Absolutely. So any patient with raised abdominal pressure, volume might be normal, but the IVC might be collapsed. So you have to exercise the caution. So small IVC doesn't always mean hypovolemia in these patients. In tricuspid regurgitation, it will be more of dilated. Yeah, but I'm talking about if you look at this kind of IVC, which is completely collapsed, during inspiration, expiration, it's completely collapsed. So if there is no intra-abdominal hypertension, abdomen is soft, patient is in shock. I'll come to that also. That's about, in TR you will not see IVC like this. I mean to say the TR, unless it's a gross hypovolemia, you will not see IVC like this. And even in TR, if in gross hypovolemia, with this IVC, we will need fluids.
Suppose patient is in a CCF, it is a global hypertension. Patient is also having fever infusion bilateral transfusion. What will be their pressure?
So patient having bilateral.
Pressure is also raised. Patient is having congestive cardiac failure. So venous pressure is high, but how it will be?
So we have to see whether the patient is in shock.
Yeah, maybe go because of congestive cardiac failure. Definitely because both sides are pain.
So
patient is having chest में देखा तो उसको image है पूरा diffusion के because of transient damage या ascites associated.
yeah.
So what will be venous appearance in this type of?
Okay. So pure effusion and ascites will work totally different for IVC.
Ascites is pure diffusion, bilateral diffusion.
So even if there is ascites, if it's a tense ascites, then IVC is not reliable. If it's a soft ascites, IVC might tell you about the CVP. Basically,
We do get cases of cirrhosis even in very tense ascites, and they may have low albumin and their BP is very low, and they are not good efficient.
yeah, definitely. No, that's what I'm telling you. So, like in patients with high intra-abdominal pressure, the IVC is collapsed because of intra-abdominal pressure, not because of low CVP.
So basically a collapsed IVC is not good. No, I'm seeing a lot of echo reports nowadays where everything else is okay, but the IVC is collapsed.
So if we do a IVC of all of us here, most of us will have collapsed IVC. But that doesn't mean it is not good. So it is the clinical context that we are looking at.
No, clinically if the patient is alright, I of course operate most of them afterwards. But then I find something like the patient has a few ectopics or maybe is hypertensive and the IVC is found to be collapsed on the echo. So that I'm tending to disregard that. Is that right?
It depends whether patient is in shock or not.
No, patient is perfectly okay.
Then you don't, then IVC is not required. This is only about patient in shock. So I am talking about use of ultrasound in patient in shock. So this will not be applicable to some patient walking to the OPD.
I was talking about like pre-operative evaluation of a general case.
Yeah. So that's the patient is walking to your OPD.
Right.
So this is not applicable to that patient. It's totally different clinical context.
Right.
So even if you look at my IVC, it will be made me collapsed. I think I should make it fill. So can I move to next? Yeah. Now we have another scenario here. This is the one IVC. This is a full IVC. It's full during entire respiration cycle. In these patients are not hypovolemic, for sure. Irrespective of the intra-abdominal pressure, ascites, anything. These are not hypovolemic. So these patients, if they are in shock, they are unlikely to get benefited by fluids. Now if this patient is not in shock, comes to your OPD, and you see this IVC, you have to see why his IVC is so high. Whether he has a tricuspid regurgitation or RV failure or early cardiac tamponade or constrictive pericarditis, there can be any diagnosis. But this IVC is not normal in a patient who is walking. As far as patient in shock is concerned, this patient, generally they don't benefit with fluid and they need vasopressor. Any exception to this? Absolutely, sir. So, the caution or exception is any patient with RV infarction, pericardial tamponade, constrictive pericarditis, these patients need high RV filling pressure. Yeah, absolutely. So any condition which needs a high RV pressure to work, even in these patients, if they are in shock, you need to give fluids. If IVC is not either fully collapsed or fully open, it's intermittent, then we are in the middle, so then we need to use other parameters to look for the fluid responsiveness. That I'm going to talk in next lecture. Absolutely. So if you want to measure IVC, you can measure IVC diameter in B mode or you can use in M mode. I'll move on to vascular ultrasound. We're looking at the deep vein thrombosis. So any patient coming in shock after your clinical assessment, you do this scan of deep vein thrombosis of femoral veins and see if we are seeing something like a hypoechoic structure. You can see some hypoechoic structure here in this femoral vein. This is a partial thrombus. Here there is a complete thrombus. Here. This femoral vein is completely thrombused. So, if you see such ultrasound, do not give compression. You are putting the probe, you are seeing this. Do not compress. Why? So this is what diagnosis is DVT. If you compress, what will be the diagnosis? Pulmonary embolism and cardiogenic shock and cardiac arrest and CPR. So you can stay anywhere. So if you see such thing, put a color Doppler and check what's happening. Now here I put color Doppler. I can see flow in the pulmonary artery. I can't see vein in the color in the pulmonary vein. This is a DVT. Now if this patient is in shock, it is very likely that DVT has gone into pulmonary artery and there is a chances of cardiogenic shock. If I get other evidence of cardiogenic shock on echo, this is support evidence. In any patient, if you are sure there is no DVT, then you can confirm by giving pressure. Okay, I'll briefly talk about lung ultrasound because this is also important when you are dealing with patient of a patient in a shock. When you are doing lung ultrasound, you have to divide lung into 6 zones. So this is anterior axillary line, posterior axillary line, parasternal line. This is nipple. So this is zone 1, 2, 3, 4. If I turn the patient, opposite side I can see zone 5 and 6. So basically when you are scanning the lung, you have to scan all the 6 areas. Same way when we auscultate a patient, we can't just auscultate on here and say your patient is okay. We have to auscultate all the areas. And most important area is, this is called Plapp's point. Like when you auscultate, you have to go as low as if you want to look for the Krebs, you can't just look here and say no Krebs. You have to go as posteriorly as laterally as possible. Same principle applies here. It is called Plapp's point. So go as posteriorly as laterally as possible, because most of the consolidation and pleural effusion are seen here. It is called Plapp's point. So now I'm just showing a couple of videos of lung ultrasound. This is normal lung sliding. I use a linear probe here, curved linear probe. I put probe here in zone 1. Look carefully here. You can see a bright white line in between 2 black shadows. These 2 black shadows are ribs, and this is the pleural line, and this line will slide with each respiration. This is a normal pattern. If I use curvilinear probe, I can see the same thing. I have to reduce the depth. I'll see the lung sliding here also. Can everyone see lung sliding here? I'll move on to the next one. Sorry. So if you're not sure, put M mode. You will see a very distinct pattern. No, this is not barcode. This is seashore. Half of the screen is like sea, half of the screen is like sand, sea, sand or seashore pattern. And why so? Because this part is not moving with respiration. Here is a pleural sliding, so everything below this will be erased. So you will have totally different pattern up and down.
These are A lines.
This is called multiple, these are A line. This is called A pattern, normal lung sliding. Just to reinforce that, put it one more slide here. Lung sliding seen in B mode and M mode. Am I clear? Suppose the lung is not getting ventilated, then you will not see lung sliding. What you will see is, this is called lung pulse. So this is not moving with respiration, but it is moving with each heartbeat. You can confirm, you can just put a hand on patient's pulse, you will appreciate it's moving with each pulse. Or if you have increase the QRS volume, with each tuck, 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 you will see this movement. That is called lung pulse. So when you see lung pulse, it means that the patient's lungs are not getting ventilated. So suppose you are intubating a patient and you put the tube in esophagus. Now you are moving. You will see this pattern. If you are intubating patient and you put the tube too much inside, it goes in right main bronchus. You will see this pattern in the left side. So, as I told you, you can use any probe, but it's for lung sliding and lung pulse, it's easy to see with the linear probe, because everything is happening in the first couple of centimeters.
One thing is that suppose the patient has got some emergency activity. Patient is having either too inside too much or collapse of the lungs. See the patient from a distance, you find that there is no chest movement on that side.
Absolutely.
Information is taken by here.
So that is after so much of experience easily identified. For someone who is a trainee, he has to earn his experience.
Because nowadays we have seen that in ICU and the PGs and are there coming and they won't see the patient, they were simply applying enthusiastic applying the gases rather than typically seeing the patient.
Madam will also agree, many times you enter in the OT and you see, and you will say, "Arey tu bahar nikal." So this all comes with the experience. This is not, but this doesn't need experience. I'm just trying to sell what I have.
How many megahertz frequency is probed?
So linear probe is 15 megahertz high frequency, and curvilinear is 3 to 5 megahertz, it's low frequency. One more thing, this is very important, pneumothorax. And I would like you to pay attention here because this is slightly different. Many times you may miss it. You look carefully. It's the same two ribs and a pleura in between, but look carefully in the pleura here. There is no lung sliding, there is no lung pulse. Can you appreciate? There is no movement of pleura here. You can see multiple A lines. There are multiple A lines, but there is no pleural sliding, no lung pulse. If you have a doubt, put M mode. And what you will see is like a barcode. Am I clear about pneumothorax? So here, can you tell me which side there is abnormality? On right side, can you see lung sliding? Yes. On left side, can you see lung sliding? Can you see lung pulse? On right side? Right side is difficult to see lung pulse because patient getting ventilated. Someone with ventilation is difficult to see lung pulse. On left side, is there lung pulse present? Right side there it is there. Right side there is also ventilation. So this is normal. Here can you see lung sliding or lung pulse? No. So what is the diagnosis on left side? Pneumothorax. If I put M mode on right side, this you can see this. On left side, you can see barcode. If you see pneumothorax, you have to confirm with lung point. You come, so you scan from up to down. At one point, you will see that here I can see lung sliding, and here there is no lung sliding. Can you appreciate? Here there is lung sliding present, here lung sliding absent. If I put M mode here, this is called lung point. If I put M mode exactly here, I will see intermittently a barcode, intermittently a seashore pattern. Am I clear? Are you able to see a barcode here and a seashore pattern here? So this is confirmation of pneumothorax. Now coming back to our case, we had this differential diagnosis: pneumonia, MI, deep vein thrombosis. So we had done the it can be pulmonary edema, it can be ARDS, it can be pneumonia. This is RVOT. This is not RV because in this view it's difficult to comment on RV. if you want to look at the RV, it's better to go for the apical 4-chamber view, look at the relative size of RV and LV. Because this way, sometimes you will see RV, sometimes you will see RVOT. And is there DVT here? DVT present or absent? Absent. So what is diagnosis in this patient who had come with breathlessness, tachycardia? What is your diagnosis? Can it be MI? So this can be a MI with congestive heart failure, pulmonary edema. That is one possibility in this patient. Also, sometimes it may be possible this is a primarily pneumonia with septic cardiomyopathy. That can also be a possibility. But these two things you have to remember. It's unlikely to be a hypovolemic shock, unlikely to be a pulmonary embolism. Yeah. So for diagnosis, that's why I not put that. I'd only put myocardial infarction, congestive cardiac failure, but that is something you need to keep in back of your mind to rule it out. Absolutely. We'll move on to next case. Yeah, we are. Shock. Shock. MI, definition of MI is by ECG. So, but if you are looking at the shock, see, all MI is a different scenario, shock is a different scenario. There is overlap. So all MI will not have shock. And shock, all cardiogenic shock will not be a MI. It can be just a hypertensive LVF. Okay. So if you want to diagnose MI, it has to be with the ECG. There has to be ST elevation or ST depression. But when you're talking about differential diagnosis of patient who has come in a shock to ED or ICU, and you want to rule out other causes like pneumothorax, cardiac tamponade, pulmonary embolism, pneumonia, and then come down to one diagnosis, it can be a cardiogenic shock. Now, cardiogenic shock occurs in either MI or congestive cardiac failure. So that is a clinical context. That will not be identified with ultrasound. Yes, sometimes you can look at the RWMA, and if you know previously there was no RWMA, now there is RWMA, it's likely to be shock. But ultimately it's MI. But if you have MI, you want to thrombolize, you need to have ECG. You can thrombolize based on the RWMA. Right? I'll move on to the next case. So patient was operated for glostectomy, and post-op day 1 patient had a hypotension. So what is the differential diagnosis here? Just based on this very limited information. It's very limited information, I agree with you. But based on this, what thought process in your mind? What could be the cause of shock? MI? What else? Absolutely. So we had the same differential diagnosis, either MI or DVT causing pulmonary embolism. These are the clinical pictures that you will see. And this is what we saw in this patient. So can anyone identify what's the abnormality here? What's there in the echo? RLV is grossly dilated. It's more than LV. It's grossly dilated. And it's so dilated that it is pushing the septum towards LV. LV has absolutely no space to fill. Okay, what is the cause of acute cor pulmonary? And so, what is seen in IVC? Dilated. What you are seeing here in the vein scan? This is pulmonary veins. So not pulmonary. This is femoral veins. You can see a thrombus here. Thrombus is there. And lung ultrasound. It's normal actually. Just to complete the list, I'll put it, it's normal here. And when we look at the parasternal short axis, we saw this thing. As I told you, RV is so grossly dilated and enlarged, it is not allowing LV to fill. Acute cor pulmonale secondary to pulmonary embolism, as indirectly evidenced by DVT. Echo cannot directly identify pulmonary embolism unless it's in the main pulmonary trunk. This is the indirect evidence. Any comments or questions so far? Okay. So this was the case, DVT with likely pulmonary embolism. This is a case of obstructive shock. We'll move on to the next case. Cough, fever, shortness of breath. And this was a differential diagnosis. It could be either pneumonia, myocardial infarction. And when we did rush examination, this is what we had found. How is heart? Contractility is good or bad? Good? Okay. What about the veins? Is DVT present or absent? DVT present or absent? Present. We're talking about this one. This is not DVT. No, this is a node. No, this is very common. It's very, sometimes this gets, you may get, this looks exactly like a vein with thrombus. What you need to do, you scan up and down. So if it's node, it will end there only. If it's vein, it will continue. The vein is here. So I'm giving compression, the vein is collapsing. This is artery, this is vein. Artery is overlapping over the vein. This is a node. This is not, there is no DVT. IVC, full or empty? IVC looks empty, right? Now, this is lung ultrasound. I'll just orient you to the structure. This is liver, this is spleen and kidney, and this is lungs. So, basically, I am scanning here on the left side. I kept the probe like this. So, this is cranial part and this is caudal part. So, what you see here, consolidation. So this is spleen. Look at the echo density of spleen and lungs. It's almost same. So this is called ultrasound hepatization. Lung is so badly consolidated, it looks like liver. And what else you see here inside? White? Can you see white lines going in and out? So this is called, what is it called? This is called dynamic air bronchogram. This is very classic diagnostic sign of consolidation. So this patient had a pneumonia and septic shock. I think you have only a couple of cases after this. So patient had a Whipple's surgery and post-surgery output was low, lactate was going up. So obviously, I mean, in interest of time, I'm skipping the differential diagnosis. I'll just going to go for the ultrasound findings. So what are you seeing here? How's heart? Contractility is good or bad? Good. IVC? Okay. Lung ultrasound? There is no B line. So if you can see A lines here, the B line is absent. Or if you see B line, the A line should disappear. These are not B lines. These are called Z lines. Yeah, you can see multiple A lines. Can you see a second A line here? Can you see this B line is not going till the end of the screen? It's getting disappearing, so it is not B line. There is no pulmonary edema. How is IVC? IVC is so collapsed you cannot see. And this is the exact point I was emphasizing. In such patient, you may very easily misdiagnose aorta as IVC. This is, can you appreciate this is a highly collapsed IVC, gross hypovolemia. Contractility is good. Lungs as of now look good. And this is the DVT scan. DVT present or absent? Absent. So, and when we did abdominal ultrasound, we found this. This is liver and this is kidney somewhere here. This is kidney and this is liver. What you see? Free fluid in abdomen. So actually this patient had pneumothorax. And there was a gross, so it's a mix septic plus septic and hypovolemic shock. The patient already had a leak, infection, and then the patient had a pneumothorax. Okay. One last case, CKD patient getting treated for diabetic foot. Initially was resuscitated, operated. Now post-op his potassium is going up. Output is low, there is metabolic acidosis. So, you can just tell me differential diagnosis here, because I'm not going to put the next, moment I put the next slide, the diagnosis is very clear.
AKI.
Okay, sir. AKI on a CKD, absolutely. Anything else? AKI secondary to shock, maybe hypoperfusion, some kind of shock. So basically what shock we are dealing with? Septic, hypovolemic, it can be a prerenal component also. Okay. Anything else? Anything you are going to do now? What you are going to do now in this patient? Normally what you do in your ward, you do to practice in wards and ICUs. So we did the echo there was no problem, IVC was okay, lung ultrasound was okay, there was no DVT. Anything else you want to see? Potassium was 6.1. So that will take some time. Serum protein never sent to the lab, but it will certainly take some time. This is on the ABG, we saw the potassium of 6.1. So we just put the probe on bladder and we saw this thing. Basically what you are seeing here, this is a urinary bladder with a Foley's in situ. Can you see Foley's bulb and a distended urinary bladder? So basically this patient had a blocked catheter. So it's a simple problem. If you just put the probe and you have this thing in mind, okay, any patient decrease urine output, just put the probe and see whether catheter is blocked. Before ultrasound, what we used to do, we used to flush the catheter to see whether there is a block. Now you don't have to do it, just put the probe and see whether there is a bladder distended. Bladder distended, either flush or change it. This is block catheter. This patient had a block catheter that... Absolutely. Absolutely. I have no... So someone, if your bladder grossly distended, patient is thin, abdomen is soft, you may palpate bladder. You may even go further, you may percuss and get the dull note, not the tympanic note of intestine. But in other patients, obese patient, there is a abdomen is tight, then you can easily identify. And this, it doesn't take more than 2 minutes. And this is objective. If I percuss, I may find a dull note, she may find a tympanic note, someone else may find, so this is a subjective. Clinical examination. Yeah. Yeah, absolutely. This patient had an infection, he went in the OT, he had a shock, so he had likely chance of having a shock leading to AKI or pre-renal failure. But this was, in this case, it was not that, it was just a block catheter.
Maybe first see the patency. If the patency is okay, it will include that. Then we can assess the other, because this is a complex situation. We cannot assess sometimes the patient is very, not because there may be associated dyspnea, and there may be hypovolemia because of some cardiac element or whatever.
Absolutely.
So here we do first assess the catheter blockage, then we do assess other patients.
Absolutely, absolutely. So, and the easiest way to assess catheter block is looking at the bladder ultrasound. It is more objective.
Sir, you mean in fast approach we have to see for sort of view also. In every patient of shock, you should take probe and sort of.
So, in FAST there are 4 views, and it all depends on the clinical context. But if you are talking about FAST view, there is a right upper quadrant, left upper quadrant, subcostal that is covered with cardiac, and the abdomen and the bladder view. And it does bladder view. In FAST you have to do all these 4 views. Then there is nothing more than 2. You put the probe, within 1 minute you have a diagnosis. Basically looking at whether the bladder is full, whether there is a free fluid collection in the abdomen.
I'm having some problem here.
Yes, sir.
All right, the bladder has 500 ml of urine. It's still in the patient and does not come out. But will it raise the potassium to 6.1?
If the
Very much, Dr. Sethi, what is your opinion?
You need to go through whether the daily potassium is 6.1 or not. Because they have this
detection of
So I had not put the baseline potassium here. So
already in case of CKD.
it's already CKD, so his potassium might be baseline potassium might be high. He has gone to the OT and then come back. So in between we don't know what was the output, whether the handover was done properly from ICU to OT, OT to ICU, whether they measured the output, they missed it. So it might be possible that the patient catheter is blocked for the next 3-4 hours. And his potassium was borderline, maybe 5.5. This is just to highlight the importance of looking at bladder in the case of when you say nose not put, suspect bladder catheter block and look at the ultrasound. So, I'll go back to that slide, madam. So there are the 3 probes. The green one is what you are supposed to do it. Blue is what you can do it. And red is you should not do it. So linear probe you can use for DVT and line cannulation. Echo probe. This is echo probe used for echo. You can use fast lung ultrasound DVT. This is abdominal probe. You should use for fast and lung ultrasound. You can use for echo and DVT. Avoid these probes for vascular cannulation. Next. Change. Is anyone there to help us for technical?
Okay, so after the excellent ultrasound session, we'll go back to physiology. Okay, and it's not as intuitive as looking at the ultrasound and taking the this thing, but it is assessment and monitoring in terms of physiology. So I'll quickly only go through what we routinely use for monitoring perfusion in cases of shock. Okay, this is not for routine monitoring. This is monitoring tissue perfusion only in the context of shock. All right. So, like Amol mentioned, for shock you do not need to have low blood pressure. Okay. So, if the perfusion is inadequate, you are probably dealing with shock. So, I will not delve too much into how to define shock. But how to diagnose clinically is from variable clinical features, like you may or may not have hypotension, you may or may not have thready pulse, but you may have signs of hypoperfusion, and there are various windows in your clinical examination where you can find signs of shock. So you may have altered menstruation because the perfusion to the brain is reduced, you may have oliguria, you may have sweating, cold clammy skins, and mottling. And now we know that shock can be even with presence of normal blood pressure. And that's the reason why surviving sepsis guidelines mentioned that you need to have objective parameters for diagnosing shock. Okay? Alright, so from the previous session we saw that the pulse pressure is an important parameter when we monitor perfusion, and you can only have pulse pressure if you have the arterial line. You will not be able to get it reliably well through a non-invasive blood pressure. So pulse pressure is one way to look at it. The other way is to look at the shock index. So if the heart rate is more than your systolic blood pressure, you are probably dealing with shock, where your shock index is more than 1. Okay, so when you say shock and when you are dealing with or monitoring tissue perfusion in shock, there are only two things which you have to consider is whether my cardiac output is adequate to give adequate tissue perfusion. Okay, that's the only basic question which we are trying to answer. And when we try to do that, we see whether the mean arterial pressure is adequate, whether your cardiac output is adequate, whether your dynamic parameters of volume responsiveness tell us that the patient is adequately filled. If you look at CVP and you say that your CVP is adequate, your RA pressures are adequate, these are all parameters that you can look at. Okay, essentially what you are trying to do is to optimize your cardiac output. Now when you say oxygen delivery to the tissues, the other two parameters that along with cardiac output is hemoglobin concentration and the oxygen content of the blood. So saturation and dissolved oxygen are the two other aspects. Dissolved oxygen is very less, saturation hypoperfusion by merely looking at the clinical aspects. So when we say cold peripheries, pale, clammy skin, mottled appearance, these are all parameters or diagnostic elements of shock. When we look at capillary refill time, if it is more than 3 seconds, you are probably dealing with shock. People have also looked at mottling score. It is very hard in Indian population, but it has been studied in West. You have got varied mottling, and this is classically seen when you are dealing with a very high grade of shock, where you actually get varied level of mottling on the skin. Okay, and it has also been quantified to define shock. Okay, so coming to capillary refill, again It is an easy way to do it. We've got a recent trial which has suggested that, looking at capillary fill time is good enough to diagnose or to tailor treatment for shock. Okay, so it is not a absolute clinical parameter. Okay, so you should be able to emphasize, or practice. So all it essentially tells us is your clinical examination is equally important. We may have all the gadgets like ultrasound and stuff like that, but always you cannot undermine the value of clinical practice and clinical exam. Okay. When we look at objective parameters, the routinely practiced parameters are lactate, mixed venous, and your acid-base status. Okay, I'll only touch base on lactate and mixed venous because that is extensively studied in terms of shock and shock resuscitation. Okay, so how many of you routinely look at lactate levels? Can I have show of hands? Only one? Okay. So it's a reasonably standard practice of looking at lactate. How many of you look at mixed venous saturation? Okay, so mixed venous is not there. It was, and because this is the practice world over, because even best of centers have started moving away from mixed venous saturation. So the use of mixed venous saturation is reduced, but I will tell you it still remains an important parameter. Okay. Whether objective or clinical parameter, you can see that is there a problem with this? Okay. Okay. So you can see that the peripheral perfusion looked at by cap refill is reasonable. Lactate is a little better in terms of its prognostic marker. Okay. We have someone from the audio visual? No? Okay. So Okay, so lactate remains a good prognostic marker. However, it is not very specific. So you may have lactate in other conditions also, which we will see. Okay. So, like I said, the recent trial which looked at capillary refill time for adequacy of resuscitation of shock was good enough. So there was no difference. So you may have read the Andromeda shock trial. There was no difference between the two groups in terms of mortality when cap refill time was used for resuscitation in shock. Okay, so if you do not have anything, you can use capillary refill time as a marker of shock, but you should be using it diligently. Okay. Then the next thing is the urine output. Now urine output has also been a reliable marker, but it is a very late marker, and it is, it may not be very specific in terms of ICU population. Okay. So when we say parameters of resuscitation and tissue perfusion, what we actually look at is the macro circulation. So when we say we are looking at the cardiac output, we are looking at the lactate, we are looking at mixed venous saturation, these are all looking at macro circulation. But what in sepsis, the problem is also the micro circulation, and we should always remember that there is nothing that we can do to target or alter the micro circulation. Okay, so we can do as much to improve the cardiac output, but by virtue of doing that, we are only targeting the macro circulation. Okay. Now, okay, so when we target the macro circulation, we do it by either giving fluids or by using vasopressors. No. Okay, I think we'll continue with this. So we either target or we optimize the cardiac output by giving fluids or vasopressors, or when we have to improve the oxygen delivery to the tissues, we use it by giving blood, okay, to improve the hemoglobin. Okay. But like I said, there is no way to alter the renal circulation or microcirculation. The newer modalities have come which look at microcirculation, but there is nothing to alter it. Okay, we can look at it, but we cannot alter it. So gastric tonometry or the OPSI is another way of looking at it. Okay, now physiology. So when we say oxygen delivery to the tissues, one is the DO2, is equal to cardiac output into hemoglobin and saturation. Now you can see that the saturation and the hemoglobin, the saturation is a very poor determinant of oxygen delivery. Though we may think that saturation is a very critical aspect of oxygen delivery, it is not. The important parameters which remain are cardiac output and hemoglobin concentration. Okay. So say if your cardiac output is 5 liters, your hemoglobin is 15 and your saturation is 98. Okay, you can see that your oxygen delivery is almost 500 into 20 is 1 liter. Okay, so this is your oxygen flux that we say. Okay, this is the oxygen. So if your cardiac output is 5 liters, hemoglobin is 15 and your saturation is 98, you are delivering 1000 mils of oxygen to the tissues. Okay, now by increasing the cardiac output or hemoglobin, you can increase the delivery, but you cannot do anything that to change the extraction from the tissues. Okay. So what the extraction depends is, you can see what is the extraction. Okay. So now the extraction or the oxygen consumption is 250 ml. Now delivery is 1000 ml, your extraction is 250 ml. So your venous saturation is almost 75. So for example, your arterial saturation is 100 and your venous saturation is 75. That means your extraction roughly is 25%. Okay, this is just for ballpark figure, but you should remember that cardiac output and hemoglobin are the major determinant, though we try to assess by looking at the venous saturation and the arterial saturation, but it is actually driven by hemoglobin and cardiac output. Okay, all right. So normal extraction ratio is 25 to 30%. So the tissues will extract 25 to 30% from what it is being delivered. The reserve is almost 75%, right? We check this when we look at mixed venous saturation. Okay, what is the extraction ratio? Now the DO2 VO2 is a coupled mechanism. Okay, so there is coupling between the delivery and the consumption. So you can see it is linear up to a certain extent. So to a certain extent, if the delivery drops, the consumption still is maintained up to a critical level where the delivery drops further, your consumption goes down, right? So this is the point we call as the critical point of DO2 VO2 curve. So here again your delivery is dropping so much that the patient will have anaerobic metabolism or lactate production, whatever all these, and this is the point where we are actually looking when we are looking at tissue perfusion. Okay, so like I said, for delivery we can optimize by giving increasing cardiac output, blood and saturation. To reduce the consumption, there is very little we can do. We can either decrease the temperature, we can either decrease the respiratory rate by ventilating them. If they are like breathing heavily and very tachypneic, you can ventilate and take away the breathing effort. But those are very little to reduce the consumption. Okay. Okay. Now when we look at mixed venous saturation, you have to remember that there are two aspects. One is the central venous saturation and mixed venous saturation. Central venous saturation is from the central vein. Mixed venous is from the pulmonary vein. We do not put PA catheters anymore, so we do not do mixed venous. So nowadays whatever we do is central venous saturation. Okay, just keep that in mind. So I'll first go through lactate. So even like I said, surviving sepsis campaign guidelines have mentioned that lactate is a useful parameter of tissue perfusion. So much so that it is also a parameter that is used to diagnose shock. Like we discussed that ultrasound cannot diagnose shock, blood pressure cannot diagnose shock. What will diagnose shock? So in a clinical setting, if you have lactate, you probably are dealing with shock. Got it? Okay. So a little bit of physiology is, see, glucose is converted to pyruvate normally, and the pyruvate enters the TCA cycle through the monocarboxylase transport proteins. Okay, we call it the MCT protein. These are oxygen dependent protein. If the oxygen is there, the pyruvate will enter. If the oxygen is not there, the pyruvate goes to lactate. Okay, and that's why we think that when oxygen is not there to the tissues, there is higher lactate production. Okay, this is what we assume. There is not much we still know about lactate, but this is what the physiology will tell us. Again, this is the Cori cycle where the lactate is moved to liver and muscle for energy substrate, but this is how the pyruvate will enter the Krebs cycle to generate 36 ATP. If this does not happen, the pyruvate will go to the lactate shuttle and generate only 2 ATP, which is not a very energy efficient mechanism. And there are various other conditions where lactate can go up. What we are more worried is lactate when it is produced because of tissue hypoperfusion. So there are there is various classification which is looking at other causes of lactate. We will not go into detail of that. So what are the difficulties in lactate interpretation? Okay, one is tissue perfusion may be normal, but the clearance is hampered. So if you have a liver dysfunction, the liver has to handle the lactate. Lactate is again produced normally also. If the liver is not able to metabolize the lactate will remain high, and we would erroneously think that there is tissue hypoperfusion, right? Then tissue perfusion is again the tissues are not able to utilize, so that can raise to high lactate, and of course there are abnormal metabolic processes. But by and large, most of the studies which have looked at lactate, any lactate more than 2.5 is a reasonable red flag because it is associated with poor outcome. So if the lactate is high, there is something wrong that is happening. Okay, that's good enough to say that. And lactate has been a serial marker in predicting mortality. Okay, so as the lactate goes high, it is linearly correlating to the incidence of mortality. And you can see that there is occult hypoperfusion and mortality in sepsis patient. You can see that even when patients are normotensive, higher lactate was associated with higher mortality. Okay, so even if the blood pressure is fine, if the lactate is high, you need to be careful. And again, this is again another study which looked at if the lactate has been persistently higher after resuscitation as well, the mortality has been high. Okay. But in sepsis, there is another mechanism why lactate is produced, and that is called as accelerated glycolysis. So what happens is, if you have higher catecholamines or higher epinephrine, it will increase the cyclic AMP. The cyclic AMP will increase the function of sodium potassium ATPase, and that will cause increase in the ADP formation from ATP, and this causes increase in the shuttle from lactate. So this is another catecholamine derived mechanism to cause increased lactate. So in sepsis, the lactate is because of higher adrenaline, higher adrenergic storm also. So just not tissue hypoperfusion, it is also because of accelerated high glycolysis because of epinephrine and anything. So if you give epinephrine nebulization or salbutamol nebulization, anything that can cause increase in the catecholamine levels in the body can cause higher lactate. This is what you need to keep in mind. It is more common in sepsis patient. If you use epinephrine instead of norepinephrine, you may have higher lactates. Okay, so that is what you need to be wary of. And it is not a bad mechanism of lactate production here. Because, see, there are patients who have not shown a lactate rise, have been associated with higher mortality. So we do not know whether lactate rise is a protective mechanism or it is a byproduct of tissue hypoperfusion. So there are many things that needs to be understood about lactate. We are only thinking lactate in one aspect, that it is a marker of tissue hypoperfusion. Okay, because see, when you say marathoners, when people do exercise or marathon and all, their lactates are very high, because lactate itself is a substrate for energy production. Brain uses lactate. So, lactate may not essentially be bad, but the mechanism by which lactate is produced may be bad. Okay, so this is what you need to understand. Okay, is lactate a good guide to treatment? You can see that the lactate guided therapy has got a lower mortality. So it's a good guide to treatment. So if the lactate is high and you institute some therapy, either fluids, vasopressors or whatever, and the lactate is cleared, you're probably doing the right thing. So lactate is a good guide for treatment. Okay, again you can see that over 6 hour period, if the lactate did not go down, the mortality was high. So whatever treatment you are doing, if the lactate stays persistently high, you are probably looking at a bad outcome. If the lactate starts coming down, you are probably having likely to have a good outcome. So similarly, at least 10% lactate clearance every 2 hours is a good ballpark figure to say that your resuscitation is adequate. Okay, because we do not know how much lactate has to reduce once I start treatment. So a 10% lactate over 2 hours is a reasonable guide. But like I said, many things we do not know about lactate. What we know is lactate is associated with increased mortality. Lactate is a biomarker of stress and not dysoxia, because there are many other mechanisms why lactate is produced, and lactate is just a messenger and you don't want to shoot the messenger. Okay, the reasons why lactate is produced may be bad, not the lactate per se. Okay, and quickly about mixed venous, venous oximetry. Now since we don't do it very often, I will just quickly touch base. It is a marker of oxygen delivery and consumption balance. That is what it is telling you. Okay, and like I said, when we say mixed venous, it is pulmonary artery. We do not do PA catheters anymore. So what we do is central vein. So central venous saturation. We've gone through this. Delivery can be only optimized by cardiac output, correction of anemia and oxygen. Okay. Now when we rearrange the fixed principle, we will know that your mixed venous or the CVO2 is the difference or the factor of arterial content, your consumption and cardiac output, right? So in other words, your mixed venous is inversely related to the consumption to cardiac output ratio. So if your consumption is high, your mixed venous will be low. Okay, that's what the bottom line is. Okay. The other thing that you have to know is your PA if you were doing your mixed venous from the pulmonary artery, in normal conditions, your central venous saturation is lower than the PA saturation, because your brain utilizes more oxygen normally. But in shock states, your gut and all utilizes more oxygen, brain oxygen is relatively preserved. So your central venous saturation is a little higher than your mixed venous. Like I said, it does not matter because we do not do PA catheters anymore. Okay. Now why do we want to know about mixed venous? Because if it is not very useful, why do we want to know? Is because this is the single most marker which has brought sepsis into clinical relevance. So this was a trial published way back in 2000. You can see this is the reverse trial, which the world over knows the trial. It looked at lactate guided therapy. So mixed venous guided therapy, which has shown mortality benefit of 46 versus 30%. So nothing in critical care will give you this much mortality difference, especially in a population with septic shock. Okay, so that's why for 20 years, surviving sepsis guidelines did mention mixed venous saturation as a target for tissue perfusion, right? But now, because we say lactate is okay, capillary refill is fine, urine output is okay, we are moving away from mixed venous. Okay? So this suggested that this was the protocol which was followed, and it is a pretty robust physiological protocol. What it says that use CVP to optimize your fluid. Okay, if you are ventilated, make it 12. If you are not ventilated, keep it more than 8. So you optimize your preload, right? You keep the MAP more than 65. You keep your mixed venous more than 70. Okay, you do it either by if your CVP is okay, your MAP is fine, your still mixed venous is low, you give blood. Okay, to increase your oxygen delivery to the tissues. And then you see, you keep the mixed venous saturation to more than 75 and you see the outcome. And like we saw, the outcomes was pretty staggering in terms of mortality. But the recent trials have shown that, even if you do your usual care, the mortality difference is not much. Okay, so your usual care is good enough, provided you do your usual care well. So either you do some sort of tissue perfusion monitoring, either lactate or capillary refill or something of that sort, then your outcomes will be okay. But you can see that the reverse patients were very, very sick. Their SCVO2s were 48 as compared to other trials where the SCVO2 was. So these are well resuscitated patients, okay, where your mixed venous was not very bad. Okay, here it says lactate versus mixed venous targeted therapy, no difference. So you can either use lactate or you can either use mixed venous, but you should use something of that sort. And the last parameter is the VaCO2 gap. How many of you have used VaCO2 gap for tissue perfusion? Okay, none. So then it is just telling you, it is just looking at your arterial and venous blood gas, and you look at the CO2 difference between the venous CO2 and the arterial CO2. If the gap is less than 6, that tells you that the cardiac output is okay. If the gap is more than 6, there is probably scope to improve your cardiac output. Okay? And you can of course incorporate your mixed venous, lactate and CO2 to determine your therapy. Okay. And of course we can use, there are various tools to look at microcirculation, but I think I will stop here and take questions if there are any.
The VaCO2 gap, you need the central vein or the peripheral vein? Or
Ideally the central vein. Ideally the central vein, because see, if you take a peripheral vein, it will reflect the regional tissue perfusion. If you look at central vein, the global one.
The other problem with peripheral vein is you tie a tourniquet. If you measure, it is only very low.
yeah, it is a false thing.
So you don't advise peripheral vein.
Yeah. Any questions?
Quite self-explanatory.
Okay, I think we'll move to the last session.
I think I'll say whenever I advise arterial gases, I will also advise central venous gases also.
So it's always a good idea to do it in parallel, and you also look at the principal saturation. Then you do a CO2 gap. So it will tell you whether to optimize your cardiac output or not.
Sir, more about this venous and arterial issue. Yes.
Yeah, so see, CO2 is extremely diffusible. It is like 20 times more diffusible than oxygen. So now your tissues are producing CO2, right? They are diffusing to the venous side. Your arterial CO2 is fixed maybe around 30-35 depending on whatever arterial. So if your tissues are producing more CO2, and there will be higher CO2 on the venous side than the arterial side. The difference may not be huge. See, normally it is less than 4, 3, 4, that's what normally you would get. If it is more than 6, then probably your tissues are producing more CO2. That means your tissue extraction is higher, oxygen is higher, the tissue
Perfusion is less.
and the perfusion is less. Okay.
Thank you, Dr. Shil, for a wonderful lecture. It was slightly difficult topic to understand and explain, but I think Shil had done explained very nicely. So obviously, just cardiac output is not just a number unless you are looking at a lactate or venous gap, because that will tell you the adequacy of perfusion. One single cardiac output number is not going to tell you anything. So someone with, as I told him, someone is a marathon runner, a cardiac output of 6 liters is inadequate for him. He will die of cardiac arrest. So I am talking about fluid responsiveness. There were some questions about how to give fluid and what to monitor and when to stop. So these are very important questions. And we should know exactly at what point of time we should give and when to stop fluids. So just a clinical scenario, patient presenting to ED with again so many comorbidities, so we started resuscitating. Patient was very sick, so we intubated the patient. Now this patient, started on NORAD. Now this patient had a cardiac history, so we are concerned about giving fluid boluses. And so we did an echo. In echo, it was a little equivocal. IVC was looking full, cardiac function was okay. There was no pulmonary edema as such, but we are not sure whether if you give more fluid, whether it's going to be more pulmonary edema. And second thing is we wanted to know whether if I give fluid, whether there is a benefit to the patient. As you can see here, patient has high lactates. That means the perfusion is low. Output is low, urine output is low. BP is on NORAD. So I need to give some resuscitation. So one thing is volume, we talk about volume status. Some patients are hypovolemic, some are hypervolemic. So this is easy. You know, someone with hypovolemia, you give fluid. Someone with hypervolemia, don't give fluid. And someone with euvolemia, you don't know. That is the problem. And in clinical scenario, it is not always very clear. You know, someone coming to casualty may be either grossly hypovolemic or hypervolemic. Moment we start treating them, they are not clearly either hypo or they are in between. Right? And we need to know in these patients how to give fluids, because fluid is a double-edged sword. If you give fluid, there might be a benefit in terms of increase in cardiac output, increase in urine output, clearance of lactate. At the same time, there is a risk of pulmonary edema. So we are basically walking on balancing on a rope. And the two important questions that we want to address, one, if I give fluid, whether there is an increase in cardiac output. Second, if I give more fluid, whether there is a pulmonary edema. And answering about these two questions will tell me whether I should give more fluids or not. So talking about fluid responsiveness, it is, if you give fluid, there is an increase in cardiac output. How much cardiac output increase? There is a defined from maximum studies they have taken stroke volume as a parameter. More than 10 to 12% increase in stroke volume is considered as patient. So if I give fluid, say 500 ml of saline, and cardiac output, stroke volume increased by 10 to 15%, that means the patient was fluid responsive. Right? Now here the key word is was. You are getting my point? So you cannot so key is I need to identify it before I give fluid. So if I give fluid, cardiac output increases, well and good. If it doesn't increase, there is a problem. If there is pulmonary edema, there is double problem. I should know it before I give the fluid. And that is the key of that I'm going to address in this lecture. So for this fluid responsiveness, we look at parameters that are known as dynamic indices. So we are not looking at one static value of hypovolemia, hypervolemia, looking at dynamic indices. What are the dynamic indices? If you had looked at the Frank-Sterling curve, this is the Frank-Sterling curve. So here there is a preload, here there is a cardiac output. You can change this to CVP, you can change to any preload parameter. And this is cardiac output, you can change to stroke volume. So basically normally in normal heart, if you give more, increase the preload, there is an increase in cardiac output. In a failing heart, they don't tolerate, they might fail. And someone with a hyperdynamic circulation, they will tolerate it better. The problem is when I look at a CVP, or suppose I say CVP is 12. I measure CVP is 12. So CVP is telling me that patient is here. CVP is not telling me whether my patient, if I give fluid, it is going to be here, here, here or here. Am I clear? So basically we are looking at a dynamic parameter. If I give more fluid, what is going to happen? Whether patient is going to respond, or patient not going to respond, or patient is going to fail. That is what I want to know. So as I told you, CVP is not accurate. So, and when you're looking at fluid responsiveness, you are not looking at the absolute number of preload, you are looking at the change in the preload, change in the cardiac output. Some patients are better fluid responsive, some are not. There are various tests available, and these tests use interaction that is known as heart-lung interaction. So basically, in a one patient, with each respiration, there is a change in intrathoracic pressure. In spontaneous, the pressure will be down, and during expiration, in control, the pressure will be up. And based on that, the patient's preload fluctuates. And you can actually look at this graph, this fluctuation by various parameters. And that this parameter will tell you whether there is a steep curve or there is a flat curve. Flat curve, unlikely to respond to fluid. Steep curve, patient more likely to respond to fluid boluses. So this is what I'm talking about. So let's assume a controlled ventilation. Patient, you are getting you are ventilating patient, there is a positive pressure. With each positive pressure, suppose many times you see in OT and ICU also, there is a change, swing in the arterial blood pressure waveform. If you don't have arterial blood pressure waveform, if you have pulse oximeter, even that, there you can see this swing. So this is a kind of, like we say in a pulsus paradox, but this is not exactly pulsus paradox, this is a different kind of swing. So basically in controlled ventilation, during positive pressure, there is an increase in LV preload, decrease in LV afterload, that's why LV cardiac output increases. And then later, during expiration, it decreases. So this is happening in each breath. And that's why we are getting a variation in pressure. So you can have a variation in stroke volume, or you can have a variation in pulse pressure. So the pulse pressure is an indirect measure of cardiac output or stroke volume. So you can have a change in pulse pressure, you can have a change in stroke volume. For this you need a cardiac output monitor. So if you see a change in stroke volume with each breath, these patients are normally fluid responsive. So you can even have a systolic pressure variation. So people have looked at various parameters: systolic pressure, stroke pulse pressure, stroke volume, aortic beta. You can have anything depending on what is available to you. But simple, if you don't have cardiac output monitor, if you are putting heart line, almost many monitors will give you this number, pulse pressure variation. You don't need a cardiac output monitor. You need to have just put a heart line, put the PPV on, PPV value more than 12, that means patient is fluid responsive. Now there is a problem here. This is validated in patient with tidal volume of 8 ml, 10 ml per kg. In ICU patients, ARDS patients, we are ventilating with low tidal volume. So it is not accurate in these patients. So coming back to PPV, so this studies have shown it is very accurate. And these are the false, but you need to know some false positive and false negative. So patient with low heart rate and high respiratory rate, it can be false negative. Patient with irregular heartbeat, it can be false positive. Low tidal volume, false negative. Intra-abdominal pressure, false positive. Open thorax, false negative. And it is not validated in patient was spontaneously breathing. So to address the problem of mechanical ventilation with low tidal volume, which is very common in our ICU, almost all patients are mechanically ventilated. So this test was developed in our institute, and where we had looked at the tidal volume challenge, we increased the tidal volume from 6 to 8 ml per kg and looked at the change in PPV. So if the change in PPV from 6 to 8, cutoff is, So the change cutoff of 3.5, it will give you a good response to that. It will tell you that patient has a very good response to fluid bolus. So that this is better than a PPV itself. The change in PPV with change in tidal volume. The other test, I'm just going to briefly tell because every test will require some or other parameter of cardiac output. So this is a end expiratory occlusion. Again, this needs a cardiac output. So the principle is, in mechanical ventilation, with each ventilation there is an increase in intrathoracic volume and decrease in venous return. So if you stop ventilating for 10 seconds, what will happen? With each beat, there is an increase in venous return. Because normally with each, when you are ventilating, there is increased pressure, so there is a decrease in preload. So you stop ventilating, don't disconnect the patient, just give end expiratory occlusion. That will cause increase in preload. If that causes increase in cardiac output, it predicts patient is fluid responsive. So these are various cutoffs described: stroke volume variation 12%, PPV 12, end expiratory occlusion, you need to have an increase in cardiac output by 5%, tidal volume challenge, it's PPV 2.5, SV 2.5%. Other parameters also I'm going to talk about in the later part of this presentation. So regarding echo, so you can look at the LVOT. So this is the apical 4-chamber view, this is the apical 5-chamber view. So this is the 5th chamber. So you put the Doppler in 5th chamber and you get the LVOT VTI. Now if you change, so this is LVOT VTI, you can measure LVOT VTI. If you decrease the, increase the speed, you can look at the variation in LVOT VTI. So here you are looking at different VTI, or you can also look at Vmax. So same principle, stroke volume with LVOT VTI directly proportional to stroke volume. So here you are looking at, so if you don't have cardiac output, you can go by this method. You can look at the change in VTI with each respiration. Again 12% is the cutoff. So LVOT VTI. Again, you know, here the problem is the tidal volume should be high. A low tidal volume will decrease the specificity, and you need a very high variation, because in echo the problem is there is a lot of intra and intra-observer variation. So even in one person, a slight change in probe, there is a change in the value. So it's difficult to interpret unless you have a very large change of almost 20%. Now all these dynamic indices, you need to be cautious in patient with RV failure. If you remember the previous clip I had shown in the patient with pulmonary embolism with RA-RV dilated, in this patient also you will get PPV, SPV high, but in this patient already RV is dilated and LV is already collapsed because of dilated RV. Here if you give fluid, it will cause more problems. So so always remember all these parameters, you should first exclude RV dysfunction by echo. Then these parameters are useful. You can use IVC diameter and ratio. I'm going to skip this IVC diameter, but if you look at the IVC diameter here, like someone has a full IVC and there's no respiratory variation, here there's respiratory variation. You can calculate the variation. In a spontaneously breathing patient, more than 50% collapse of IVC is considered to be fluid responsive. In patient with controlled ventilation, so if the cutoff is 12% or 18% depending on what if you take mean diameter, it is 12% cutoff. If you take minimum diameter, cutoff is 18%. More than 18% variation. In controlled ventilation, there is distension, not collapse. So just to answer your question, when to give fluid and when to not give fluid, simple. So if the patient is hypovolemic and patient has shock, you give fluids. If the patient is hypovolemic and shock is not there, don't give fluids. If the patient is not hypovolemic and shock is present, then what to do? Then you look at dynamic indices to look for response to fluid boluses. Also look at safety limits. Now you can choose whatever safety limit you want to choose. You can, I may choose CVP also. You choose any, you can use B lines in lung ultrasound. If you are having cardiac output monitor, PICO monitor, there is an extravascular lung water. You can have a global endoscopic volume. Many parameters available. You need to understand that what you are looking at. Because PPV will not tell you whether the patient will have pulmonary edema. PPV will tell you that patient will respond to fluid. Same patient, after you give fluid, he may get pulmonary edema also. So you have to see both. And patients is hypervolemic and there is no shock, maybe you can try fluid restriction and diuretic. So I hope that answers the question of how to titrate your fluid therapy. And as I told you, fluid is double-edged sword, and you need to know before, whether patient is going to respond to fluid bolus before giving the fluid, right? So is there other method of doing it? Can you give fluid without giving fluid? Here's the next. So that is, so you can use passive leg raising, because here there is an endogenous fluid challenge, and the blood from the legs when splanchnic circulation will go into the central compartment. This can be used in almost all patients. Patients breathing spontaneously, patient having arrhythmias, patient having low tidal volume. It can be repeated any number of times. If you want to, you can also give fluid bolus or mini fluid bolus, but if you repeat more, it will cause more pulmonary edema. Here, passive leg raising you can repeat a many number of times. How to do it? Normally all the patients are lying down like this, 45 degree. So just make tendon work, head end should be flat, leg end should be raised 45 degrees. Not this way, avoid patient being supine, this is less accurate. So when you turn the patient from propped up to supine, so basically what you are doing, you are changing this control, tendon work. So you have blood in the legs. As you make the patient tendon work, this blood will go in the central compartment. It will cause an endogenous fluid challenge. And now you have to look at the end point. End point should not be blood pressure. End point should not be heart rate. End point has to be a cardiac output monitor. Either stroke volume, cardiac output, VTI, ETCO2. Because all these are indirect markers of cardiac output. So look at the cardiac output. There is a change in 12% of cardiac output. So this is a cardiac output monitor. This is a patient. You give PLR here. There is an increase in cardiac output. PLR stopped. Cardiac output goes back to normal. This is very important. You give PLR, there is increase in cardiac output. Once you get the PLR back to normal, the cardiac output should go back to the previous level. If it is not, what was the reason? So for example, you have not told the patient what you are going to do, and you just make the patient head low. Now the patient is anxious, there is adrenal stimulation, and that is causing increase in cardiac output. So that is not a positive PLR. So for positive PLR, the cardiac output should go back to normal moment the PLR you go back from PLR to normal position. You can look at esophageal Doppler, transthoracic echo, cardiac output monitor, many parameters, but avoid using blood pressure or heart rate. So make sure that, just to summarize, bed should be 45 degree, don't touch the patient, avoid touching, pain, awakening, use real cardiac output monitor, not only blood pressure, and it should return to baseline after the patient is supine. So this is not, PLR is not same as Trendelenburg test. Trendelenburg test is a treatment that we do for patient with severe shock as a temporary measure. This is a treatment. This is a test to identify increase in cardiac output. They are not same. There are many advantages of PLR, like you can be done a number of times in any patients. Obviously, there are some contraindications, like it is very labor intensive. You have to leave everything. So if you have 10 patients and you have 2 staff, you can't do PLR. Now you can't just look at only one patient and forget all other patients. So you have to have good number of resources, cardiac output monitor. Now suppose patient is very grossly hypovolemic, then there is no blood, very less blood in the splanchnic circulation and in legs. Then your PLR will be false negative. If the patient has DVT, patient has increased intraabdominal pressure, the blood will not go into central compartment. Patient has stocking. Again, the blood amount of blood that is going to for the PLR is less. So these are the false negative, and it's contraindicated in patient with head trauma, raised ICP, and limb fractures. As I told before, for the cardiac output monitor, if you're using echo, you need to have a very high threshold. So if you're using, for example, using VTI for cardiac output, if I do one VTI and I do after 2 minutes, there can be 11% variation, just without any change in cardiac output. If I am doing and Sheil is doing next one, there can be almost 15% change. This is the intra-abdominal variation. So if you are doing VTI, you need to have a very high cutoff, up to 20%. Then it's accurate. And the expiratory test I actually had echo had covered. And yeah, this is the last slide of my talk. So this will summarize the almost all tests of fluid responsiveness, starting from stroke volume, pulse pressure variation, and expiratory occlusion, tidal volume challenge, fluid challenge, just give fluid challenge, mini fluid challenge, PLR. These are the cutoffs. This in spontaneously breathing patient, you can use only these 3 tests. In control, you can use all tests. In patient with low tidal volume, you can use only these number of tests. And the best part here is PLR and mini fluid challenge, which can be used in all patients, except the mini fluid challenge is not reversible and PLR is reversible. So I'm happy to take any questions. Okay, I didn't get what. This one, yeah. Fluid challenge, the idea is, so there are different studies, but the generally accepted thing is, you can give crystalloid also, for that matter. Because here the type of fluid is not important, what is important is the rate of fluid. So you need to give a small amount in a very short period.
Getting what I am telling that we cannot simply give this fluid. We have to use a pressure injector.
It has to be through pressure injector.
Yeah.
It has to be. Even you can use crystalloid, that's for that matter. The key is to challenge the circulatory system with a good amount of fluid in a short. So faster you give, you have to give less fluid. Yeah. Thank you.
Do you have any questions from the debates? Lights on the table.
quality is a different part and central is a different part. There is a overall teamwork and one who is delivering the things,
But we are progressing towards
yes,
what
we
we
are
want to
progressing.
be.
There is no
So we have a portable ultrasonic, portable ultrasonic OT
Yes.
at both the pediatric and the ICUs. And we are now slowly, we have a workshop on ultrasound and then we will try to, do these parameters and assess the patient as fast as you have said within an hour.
I'm not this gray area. I think clear that critical care is there. You are going to approve each and every.
We are
Thank you so much. Thank you so much.